It's quite bad. I think it's quite rampant now. Even in China, they have a pandemic.
We are like.
A very good evening to, can you hear me, Mr. Sunil? It's clear?
Yes, ma'am.
Yeah. A very good evening to one and all of you for yet another very interesting webinar on secondary IOLs. I think this was one component which had not got covered in my 3-year tenure. And I really look forward to the wonderful, innovative procedures which is available in our country. And I'm sure the next 2.5 hours or more is going to be packed with learning of a different kind. We are truly lucky to have with us Dr. Anand Rajendran, who's the Chief of the Retina Vitreous Services based at Eye Care Systems in Chennai. We have with us Dr. Preetham Saman, Senior Consultant Ophthalmologist, consultant from Individual Hospital and Medical Research Center. Joining us soon is Dr. Naresh Shetty, who heads the Department of Cancer and is the Vice Chairman of the Joining us soon, Earl Fernandez, who's the Network Finance and Accounts and also Director of LVPI.
Dr. Joshi.
Is the dynamic.
Madam, you can switch off your video and try. Your voice is breaking.
Okay. Can you hear me now?
Yeah.
Yeah. Srinivas Joshi, who's a Director of Community Services from the MM Joshi Eye Hospital. And we shall now, without wasting a moment, go on to our first speaker, Dr. Ashray Naika, who's a Senior Consultant Vitreous Retina and Uvea Services at the Eye Foundation Group of Hospital based at Coimbatore. And he is going to set it off with his topic, Scleral Fixated IOLs. On to you, Ashray.
Thank you, ma'am. Hope my slides are visible.
Yeah.
Yes, sir.
At the outset, thank you, Chitra ma'am, Srinivas sir, for having me here. I would be talking on scleral fixated IOLs. These are my financial disclosure. The recent ACRS and ECSRS survey on foldable IOLs requiring explantation or secondary intervention told the most common complications associated with single-piece and 3-piece acrylic or any kind of IOLs were dislocation and decentration. So amongst all the IOLs, the 3-piece IOLs were the ones which were involved with these kind of complications. So to fix these complications, there are multiple techniques which are being described. This article reviewed around 45 peer-reviewed journals and compared different techniques, that is AC IOL, iris fixation, suture scleral fixation, and intrascleral haptic fixation. However, with regard to visual acuity, there was no consensus on which secondary IOL technique is superior. Overall complications like anterior-uveitis, CME, glaucoma, and RD were least in the intrascleral fixation group. So whenever we have to fix an IOL, SFIOL, that is a scleral fixed IOL, we have one of these scenarios which we always face. That is either the patient has a lens or the IOL which are subluxed and it's beyond repositioning, or if the patient has an IOL that cannot be repositioned, or having a massive subluxation and tilt, or when the patient has innocuous looking aphakia, but on OCT you can see the vitreous prolapse causing intersegment problems, or when patient has a defective with an IOL has a defective vision because of the Scleral force effect or associated problems such as vitreous prolapse in AC or IOL tilt causing massive astigmatism. So in 2007, Sharad Gaber gave this landmark technique, or where he described this technique where he used to fix the IOL haptics into the sclera by creating a scleral tunnel. This technique didn't require sutures and didn't have suture-related complications, and provided excellent results with less IOL treatment and post-operative astigmatism. So the goal of any surgery is to restore the anatomy, especially we should not meddle with the angle anatomy, and the overall goal should be preserved in preserving the angle and iris anatomy. By distorting any of it will have long-term consequences. So Shira techniques, basically the main point was to fix the sclera at 2 mm, avoiding that dangerous area of this of the angle, and making an putting the IOL in an alignment which is at least 180 degrees apart, and giving a position which is almost similar to the effective lens position of pseudophakia. So coming to the technique, in this patient, in this technique, after doing a standard 3-port vitrectomy, here we need to create conjunctive flaps at 3 and 9 o'clock. For the sclerotomies, this is the most important step, where we mark it at exactly 180 degree, and with the help of a caliber, mark those sclerotomies at 2 mm, avoiding that dangerous area of the angle. And with the injector, inject the IOL in the anterior segment, and externalize the haptic with the forceps. So by there's a similarly doing it on the other side to externalize the other haptic, and partial thickness scleral tunnel is created, and this IOL is being tucked into the tunnel. This is which gives the stability to the technique, and the conjunctive flaps were simply sutured with the help of a 80Y3. So the same technique can be used to fix if the IOL is intact but it is dislocated. After doing a 3-port vitrectomy, it can be just without explanting it, it can be just exteriorized on both the sides, and tunnel can be created as described previously. And this was a modification by Amar Agarwal et al., where they used glue to seal off the scleral flaps. So this technique is so stable and gives excellent results. This was a case of a multifocal IOL which got dislocated, and while explanting an multifocal IOL, care should be taken not to destroy the circular anatomy of the pupil. And after careful explantation, as described, the sclerotomies should be at 180 degree and at equidistant from the limbus to give this perfect alignment. And then 3-piece multifocal IOL has been inserted. Again, care to be has to be taken not to destroy the circular anatomy of the pupil. So once done, again, it has to be tucked into the Charlotte's tunnel. This is what gives an excellent outcome. And this is, in this case, you can see we could maintain absolute centration with the circular pupil and had a absolutely normal IOL alignment. And we could even get uncorrected visual acuity of 6/6 and N6 in this case. And this can be this is only possible because of this IOL haptic in Charlotte's tunnel, which gives also the stability. All the later modifications were basically a rehash of the same technique. So again, we can achieve an excellent IOL centration. And even this study which compared the conventional scleral fixation technique and the iris claw technique and the intrascleral fixation technique, when they compared both uncorrected visual acuity and the best corrected visual acuity, though it was not statistically significant, you can see the intrascleral group had much better visual acuity compared to the other two. So having a compromised capsular support is real life is real. We can all have that. If not managed properly, we can have medical legal issues, as in the PCJ case. So judicious management is necessary. So PCR needs to be managed well without compromising the final visual outcome, not worrying about too much on the table. And if you see this Kim et al. By the Korean journal, where they compared the three groups, you can see the intracellular group had the minimum complication when compared to the conventional and the iris fixated groups. So in conclude, scleral fixated IOLs have a shorter operative time and has no complications related to suturing, and there are no additional costs compared to the conventional scleral fixation. Great visual outcomes can be achieved, and it can be in the era of refractive surgery, can be a refractive doppelganger. Thank you.
Very nice, Ashraya. I think you showed the Sharait's tunnel how to go about that. But just one point is, I think you can, the smaller the gauge used, like if it's a 26 or 27 gauge entry into the scleral wound, what you are making is always the better, I feel, because in case if it slips down, then it doesn't go into the vitreous cavity. So the smaller the wound, I feel, is better. And we can even use the 27 gauge focus. That is how I do it nowadays. I'm sure that you also might be trying about that. I think it's open to the panel discussion. We'll ask Dr. Anand Rajendran, sir. Yes, sir. Is this your favorite technique, and what are the pros and cons of this technique? What do you feel?
Absolutely. I think there's absolutely ingenious of Gabor Shariat to develop this technique, and he actually described it to us when he came over to Ireland. He was lying down sleeping one night, and suddenly he woke up, and then he had this eureka moment, and then he kind of discovered and put it forth. So I think one issue with sutured scleral fixated IOLs that we've had is, at time down the line, they get eroded and then we find dislocation. So this is that way a better, more durable technique. So that's number one. And a few caveats here is, you mentioned it in brief during your surgical procedure, and I compliment you for beautiful videos, is that it's very important with this technique to get those exit wounds from where the haptics come out exactly 180 degrees. So one of the issues with this technique is a little bit of decentration. That's one of the commonest pitfalls of this technique. I personally love this technique. The issue is sometimes people don't get that 180 degrees absolutely perfectly. So that is one thing, because if it's less or more than that 180 degrees, there will be a little loop hang, and that IOL, one side will get tilted. The second thing is you have to have almost equivalent amounts of the haptic in the tunnels each, which means to say both the embedded aspects in the intrascleral tunnels have to be similar. Again, if one side is shorter than the other, you will again have a tilt happening there. Also, just a little, because you used the gauge that you used, I saw you have both the haptics out, and then you individually went to tuck both of them. So that's acceptable. A lot of my colleagues do it. But what I also like to do is, tuck one end in. So when you're handling the other end, this one doesn't slip through. So that is also one little issue. Sometimes that gets decentered a little, and then you're tugging on either side. Also, a fourth point, if I might add, is that when you're grasping that haptic, the handshake, that is the most critical aspect where people are a little, worried about dropping it. That handshake, from exteriorizing that haptic. So you need to grasp that haptic at almost, if I may say, like something like this, rather than this, because if you come out like this, you will be going against that pole, the exit pole, and then you might slip off and it might break that haptic. So these are a few things. We can talk a lot, and it might come from others, but this is a lovely technique, and I think this is made life easier for a lot of us.
To kind scleral fixation with a retinal detachment surgery happening at the same time, Dr. Preetham? Dr. Preetham, can you hear me?
You're muted, Preetham.
Can you repeat, madam? I didn't hear the question.
No. Scleral fixated IOL and a retinal detachment surgery, would you combine them as surgeries, or you feel there are certain difficulties, and if so, what are they? What could they?
Normally, I personally, I would do it as a two-step surgery. Do the retinal detachment first, and probably then combine it with, let's say, if you're removing silicone oil, then I would combine it with the silicone oil removal.
Yeah, I agree with Preetham. I think Preetham's connection is a little spotty. One of the reasons is I would also agree with doing it as a two-step procedure is because
Yeah.
you're doing a long surgery.
For the
And
simple reason that when you're IOL, you don't have over there. Can
Preetham,
you hear
your
madam,
is
can you hear
not
me?
good. Yeah.
Okay. Is it better now?
it's
Yeah.
better.
It is much better.
Yeah. Okay.
Go ahead.
Okay. Okay. So, I personally, I prefer to do it I would prefer to do it as a two-step procedure where, I would repair the retinal detachment first, and probably at the time of removing the silicone oil, I would combine it with a scleral fixated IOL. The simple reason being that when you're putting a scleral fixated IOL, it is because you don't have a posterior capsular support there. So, you can always have silicone oil coming into the anterior chamber. There could be a shallow anterior chamber. All these things can be avoided by doing a 6 o'clock peripheral iridectomy, but I would
Yes.
prefer to do it as a two-step procedure.
Yes.
Thank you. Thank you, Preetham sir. A quick question to Anirudh sir here. Sir, for the
I
beginners,
want
I
to
just
add
want to know
another
because
thing,
many of them.
what Dr. Preetham said. Another advantage of doing a two-step is if the retina gets redetached, so unnecessary there will be and difficult surgery. So it's always better when we know the retina is settled well, remove the oil, and then in a second step, you do as SFIOL or IOS glow, whatever you will.
I just add one little point that when you're doing a RD surgery, it's a long surgery, it's 1.5 hours, 2 hours. You can get a lot of pigment outflow also. And then one of the biggest banes of this, the patient has to live with an IOL for the rest of his life. This clumps of pigments stuck on the IOL surface, that is very painful in case the patient has good vision. And once you do the RD surgery, settle the patient with oil, you can then take a judgment call as to whether the vision has improved to the level where an IOL is worthwhile. So that you'll know at the time of SOR. So in case due to the RG surgery, God forbid, is still 3/60 or 1/60 with the veiled disc, then doesn't make much sense. So these are 2 points.
Dr.
Yes,
Naren,
Naren wants to have a quick word.
yes, Dr. Naren.
Yes, ma'am. Actually, wonderful surgery, sir, Dr. Ashra. And I just want to make a point. I think, as you all know, one of the cases which you showed was a trifocal where you placed it in the sulcus. I mean, in an experienced hand, maybe it'll work, but in a non-experienced hands, the small amount of tilt and the decentration can lead to very, very significant issues in these patients. I would highly recommend, at least for the beginners, not to try this. It's a bad idea. Yeah, it's better to go with the monofocal because it is already a dropped lens. So it's already a very high risk. There can be retina issues in the future. So, placing back the multifocal IOL, a monofocal would be a better idea. Thank you.
Yeah, good take-home message. He just showed that even that lens can be implanted in that.
Yeah.
Good.
Yeah.
Thank you.
So, shall we go on to our next speaker? Dr. Parth, you are there? Parth Rana. Dr. Parth Rana is a senior retina consultant at Netralaya Super Specialty Eye Hospital at Ahmedabad, and he's going to show his novel technique of scleral tuck IOLs. On to you, doctor.
Thank you so much, ma'am, for giving me this opportunity. Here I am sharing my patented scleral tuck IOL. So, is it visible?
Yeah. Yes.
Yes,
Yeah. Yes.
Okay. Yeah. So this is my patented scleral tuck IOL.
Scleral Tuck IOL is designed to simplify the complex surgery of scleral fixated IOL and reduce the cost significantly. This design of next generation of scleral fixated intraocular lens is inspired from the price tag label on clothes. Scleral Tuck IOL is made up of 4 different parts: flipper, neck, haptics, and optic. Placing of the Scleral Tuck IOL is an effortless technique. We inject the IOL in anterior chamber with injector and place it on iris. Lens is then rotated in horizontal position. Then the eyelet of the flipper is engaged with the help of 20 gauge vitreous forceps and flipper is pulled out of sclerotomy. Same thing is repeated on the other side. Once flipper is out,
So this
it
is
is
the
checked
real-life
twice.
implantation of Scleral IOL. As you can see here, I am just injecting this IOL from main scleral tunnel. I have just pushed it inside, and the flipper I have holded with this ILM forceps, and it's out. And on the other side, it's the same thing done. Like as you can see here, it's a simple handshake. Once it's done, once the flipper is pulled out, the surgery is over. So it's a very simple technique, very simple things. We don't need many of specialized instrument or design instruments are not needed here. I'll just show you one more implantation video from another doctor. So this is from Dr. Rohit Agrawal from MP. So here it is his video. So this was a subluxated IOL in this subluxated.
Some network issue?
Parth, are you there?
But some issue the network.
We can go to the next speaker,
Mr.
madam,
Sunil?
and once he comes back.
Hello.
Yeah, he's
Is it audible?
just back.
Yes, Parth.
No, I think you see, there's some network at your level. You
Okay,
find out who
shall
are the people with network? Yeah.
Shall I share it again? Is it visible now?
Yeah, share not.
Yeah.
Is there? Okay.
Yeah.
So this is a video from Dr. Rohit Agrawal from MP. So this is subluxated IOL. He did lensectomy first, and post lensectomy he injected this Scleral IOL. So the places where we usually do our sclerotomies for injecting this Scleral IOL, he has done sclerotomies for trocar at that same place only. And from that 25 gauge sclerotomies only, he's pulling this out, as you can see here. So once the visualization of flipper is done, then he has held it with max grip forceps, and he has pulled it out on one side. And as you can see it here, it is totally out. Once it is totally out, it can't go back in. And on other side also, it's the same thing is done. He's just doing it for visualization because optic is bigger here. So that's why we need to maneuver this IOL properly. And once, as you can see here, this flipper is out from both the sides and the surgery is over. Finally, this sutures were taken just to stabilize the flippers and this scleral flaps. And it's a quite simple surgery, and not much of the instruments are needed in this. Thank you.
Thank you, Dr. Bhatt. I don't know whether I think I should direct the question to you. What is the optic size of your scleral tuck IOL?
Optic size, it's a 6 millimeter one.
Okay, 6 millimeter, and you can insert it through a 2.8 millimeter incision, right?
Yes.
Yes. As far as the tucking part of it, the O-line sclera, there is no such thing like erosion of the flipper, that such a thing doesn't happen, right?
Usually don't happen because this flipper is made from soft material and it is curved on the top part. So usually erosion doesn't occur. And even sometimes like we have injected it just under the conjunctiva also, there also we didn't find much of the issue. Because after 3 to 6 months, there will be a encapsulation of fibrosis over that. So this fibrosis usually settles there and there's no problem in that.
Okay. Okay. Dr. Srinivas, you have anything to ask? Yes, Dr. Mehti.
Dr. Parth, very nice innovation. Like, I just wanted to ask this flipper, is there any chance of injuring the flipper and the lens damaging and dislodging into the vitreous cavity? Is like, what is the exact position you take out the flipper?
Flipper, once we are pulling it out properly, if we can see this flipper is properly out, then it can't go back in. The design is like a price tag label. So as you can see the T point, the junction of neck is around 0.8 millimeters and the width of this flipper is 1.5 millimeter. So, and this is little bit shorter than the size of eyeball. So it is usually stretched. As we can see here, it is round, as we can see, we have seen in photo. But if properly, if we see inside the eye, it is in V shape. This haptics are in V shape because this is pulled. So once this is pulled and the flipper is in horizontal position, it can't go back in unless until if we have made this sclerotomy bigger or some hypotonous eye where we have not measured the sclerotomy properly, there it can be the issue. There we need to take some sutures.
I got your point that once it is out, it will not dislodge. The chances of injury, because that's a foldable material and it can be injured, right? Did you get any cases where the flipper got injured and it dislodged?
No, till now we haven't got any case like that. But yeah, once I happened to have one case like where I pulled the flipper too much and the neck got break during the surgery, right. And I had to replace it. Because if we pull it too much, this neck is of size of 0.8 millimeter. It can be stretched up to 1 millimeter, not more than that. If we are pulling more, or maybe like if we are doing it topical, like in phaco surgery, and if patient moves the eye during that time when we are pulling this flipper, if it pulls, if it has got pulled more, then neck can break. Otherwise, there are till now I have not faced any of the issue for flipper as such.
There is a lens from the Appaswamy CMT Flex. It is also based on the same principle, I believe.
So that is a kind of legal issue.
Okay.
We have already raised before. So that was kind of copying of the same thing what I designed in 2015-16. It was the same thing. My first video was already on iTube in 2016. And then this design came. Even one Israeli doctor also did the same thing. One doctor also made something like that. So I don't have any financial issues because I'm not earning anything. This is my design. I designed for some poor people in periphery where like they can't afford glued IOLs or sutured IOLs. So I actually don't mind much of the things, but that is these are my patents. So there's a legal issue is there. But I don't want to pull it more.
Yeah. Okay. Thanks a lot, Dr. Parth. That was a nice innovative you showed. Srinivas, you have anything to ask? Shall we move on to our next speaker?
Yeah. We can move ahead.
Yeah.
Thanks, Parth.
Thanks a lot, Parth. We shall now go on to our third speaker, Dr. Priya Naran, who's a senior cataract and refractive surgeon from Narang Eye Care and Laser Center based at Ahmedabad. Another very innovative surgeon, and she's going to be talking to us on glued SFIOL.
I hope my screen is visible to everybody.
Yeah.
Yes. Thank you so much, Dr. Chitra, for having me here. And I'm so thankful to you for this. And Dr. Chitra, she wanted me to talk on glued IOLs. So that's what I'm just going to talk about. I'm just going to show, we all know that we all started with the Gabor chariot and then came the glued IOL, the modification, the flaps, and then further many techniques they kept on coming up. And I will be showcasing in the glued IOL my method of haptic externalization, which I call it as the no assistant technique. So which I got published into the Journal of Cataract and Refractive Surgery. Well, I'm going to show a very basic video. I think I just chose this video for the benefit of audience who would be probably seeing this. This is a simple case of aphakia, a case referred to me. There was a complication in the morning, and in the afternoon, I took up this case for surgery. As you see that the anterior chamber is well formed and the surgeon has done quite a bit of vitrectomy and air bubble is there in the anterior chamber. So I've just taken up this case. We begin with 180-degree markings. Let me tell, the 180-degree axis marking is common to any technique of intrascleral fixation. So that's a prerequisite. Then we go ahead with making of these partial scleral thickness flaps, which are again to be made along the axis. And especially what we need to be careful is we should have fluid infusion inside the eye. And this is an old video where I was using a 21 gauge, but now we use 23 gauge to make this sclerotomy thing inside the eye. The point of contention is that, you know, the sclerotomy site has to be exactly 180 degrees to prevent any decentration in the postoperative period. So now this corneal tunnel is made, and this is a 3-piece intraocular lens which has been loaded, and we are slowly trying to unfold this intraocular lens inside the eye, and you have to hold the tip of the haptic. You don't have to hold the haptic from anywhere else except the tip. Once you have grasped the tip of the haptic and the entire intraocular lens has unfolded, you pull the leading haptic and you externalize it. So this is what you see here. The leading haptic is now being pulled and you have the leading haptic outside the eye. Now, this is a no assistant technique wherein, you know, you flex the trailing haptic, you go much more towards 6 o'clock position, and then it's just the physics that works, and your haptic, leading haptic is lying free, and you don't need anybody to hold that haptic, and that haptic is not going anywhere. It's going to remain fully externalized throughout the entire surgery. This is the handshake technique described by Dr. Agarwal. That's a transfer of haptics from one hand to another. You always hold it at the tip and then you externalize the haptic. So that's the principle. These are a few basic principles that we need to understand when we go ahead with the intrascleral fixation techniques. And this is especially for the glue technique. And then this is the tucking of the haptics, which is going on. Another thing that you are going to see here is that you see here that there is a kink in the haptic. And why did this kink happen? This kink happened because probably I was not holding the tip of the haptic. Many times when you try to straighten, it breaks, but you have to be lucky that you have a residual good amount of haptic left to tuck inside. If you do not have a residual good amount of haptic left with you, the only alternative left for you is to remove that intraocular lens and redo the entire procedure. So externalization of the haptics is the key to doing this surgical procedure, and then you can just seal the flaps with the glue and you're sealing up the conjunctiva and everything. Glue does not give strength to the intrascleral fixation. It only helps to prevent postoperative hypertrophy. The intrascleral fixation comes up with the amount of tucking of the haptic that has been done into the scleral pockets. So that's the most important part of it. That needs to be taken care of, and we always plan to have at around, you know, maybe around 2 millimeters of the haptic that goes inside. So just to show one more video, this is just a 3-piece intraocular lens, subluxated. The beauty of this is that, you know, if you particularly see this case, there are many options that you can choose, and you can choose whatever works best for you. But when you have an unstable subluxated intraocular lens like that, and especially when it's a 3-piece intraocular lens, the best thing, if you're an expert in doing it, the best thing is to hold it up and, you know, externalize the same haptics and finish up. You are done with other calculations like IOL power calculations and other things. The only thing that you need to do is, you know, you need to do a good amount of vitrectomy. You need to clear off the entire thing which is present out there in your field. Many surgeons for this specific case, you know, we had a good amount of discussion that what should actually be done for this case, because you have a good amount of posterior capsule. There is an opening out there. You can even go in and do an optic capture. But then the views of different surgeons are always different. You know, what works best for me does not work good for you. So this patient also had quite a bit amount of after cataract and sombering. So there was quite a bit amount of astigmatism also. So coming up to this case, you know, we are just externalizing, again, hold the tip of the haptic and externalize it. That's the key to this surgical technique. You can give this haptic to an assistant who can hold it for you. You can use the iris hooks The plugs of the iris hooks are also used. That was described by Dr. Baiko and Dr. Roger Stannard. You can use that to hold the tip of the haptic to prevent it from slipping inside. So there are multiple ways that you can do that. And once you have westernized these haptics, the things, they work very simple for you. You just cut these haptics and you're almost done. So I've just covered the basic things for the glue dial, which I was supposed to cover up in this. I hope that was helpful. This is one of the books that got published and for optimizing that, for optimizing outcomes in cataract surgery. Thank you so much for your kind attention.
Thanks, Dr. Priya, for giving all those very salient, relevant points. So when you apply the glue, do you apply the glue only, anyway the haptic is tucked in the tunnel. So do you apply the glue under the scleral flap also, or it's only to close the conjunctiva?
No, it's for the flaps also, because that's where, you know, the leakage occurs. So you have to seal the flaps and then you can use it, the remaining part, you can use it to seal up the conjunctiva. So that works like. Because actually, when we do, it's like having two big openings inside the eye. You know, these are two big openings on either side. So the better, the lesser the hypertrophy you have in the postoperative period, the better. There is always a question that what if you don't use a glue? Okay, if you want to cut down the cost, don't use a glue. I mean, I've seen surgeons, they take sutures in the flap and then they seal it off. Even that can be done. But when you're doing that, I would say that your sclerotomy has to be very, very small. Like it should be 23 or maybe around that, because then with big sclerotomies, you cannot just leave them open and take a suture and go away, because it works like two filtration surgeries in one eye. So that can lead to a lot of amount of hypertony. And I think there are so many retinal surgeons here, you know, they will always, they're going to endorse it that yes, you need, the one thing that you don't want is a postoperative hypertony in these cases. So fluid infusion is a must and you need to seal up everything very well.
Yes.
I agree with Priya madam. Actually, these haptics, these go under the 30 gauge thin board needle also.
Yes.
So need not be 23 gauge. Even you can use a 25 gauge or a 27 gauge stroke cuff if you have availability for that. Otherwise, the easiest way is to go with a 26 gauge needle.
See, I tell you one thing. No, I'll come to this point. If you make a 23 gauge sclerotomy, I'm talking for the sclerotomy, you can use a 25 gauge forceps to externalize the haptics. And
No, I'm talking about sclerotomy only.
The smaller the size of that forceps, you're not going to go beyond 25. I don't know if you have for that. It does not hold the haptic properly. So the ideal combination works for holding the forceps is a 25 gauge forceps.
Yeah, so even you can use a 27 gauge, right? Because the lesser the sclerotomy wound will be, in case if you're not gluing it. If you're not gluing it and if you're just suturing it,
yes,
there are chances that it might slip back.
That is, yes, especially you know when you're doing a Yamane or something like that for an intrascleral, we all just use 26, 27, 30. So that works very well. Yes.
Anything else, Dr. Anand and Dr. Aniruddha, you have anything to add on this? Dr. Preetham?
Can I make a point here?
Yeah.
Yeah. You know, this is Dr. Preetham. I'm just making a small point, you know, and that is about hemostasis. You know, these, whenever we are making these scleral flaps, we'll always encounter, you know, those superficial bleeds from the sclera. Now, when we use a bipolar cautery, it's very important to make sure that there is absolute hemostasis, and especially after making the flap, sometimes deep vessels also, you know, bleed. And what happens is when you're tucking the haptic, sometimes these clots come in the way. Now, if you try to cauterize at that time, your haptics are in the vicinity. So that becomes a little messy cauterizing at that time. So there's a word of caution that before we externalize the haptics, make sure that your hemostasis is good and there are no bleeders over there.
Absolutely. And I would like to add one very fine surgical nuance in this at this point is that having a fluid infusion, when you have a fluid infusion and we go to the clinical situation where Dr. Samant says that there is a bleeding which is occurring at the sclerotomy site somewhere. The moment you go into a state of hypertony, that blood tends to trickle inside the eye. When you have a good fluid infusion, you know, it keeps on pushing the entire blood out there and then you get some amount of time to handle that case properly. The second thing that I think I wanted to add to this was that this is actually a very good clinical point which Dr. Samant has said regarding having the blood That's
Can
that
you,
makes,
can Dr.
that makes
Priya,
sense.
could you please expand on the physics you said about the lens staying there, haptic staying there when you're introducing the trailing haptic? You said there is physics involved in this. Can you just mention where the optic should be so that the initial haptic will not come back out?
Okay, you're talking about the no assistant technique, what I do.
Yeah, yes.
Yes. So what we do in the no assistant technique is that the step is simple, that you externalize the leading haptic. So we all know that. And then you just hold the trailing haptic, you flex it inside the eye, and you don't keep the haptic towards the corneal incision. You just take it towards the 6 o'clock, opposite direction, towards the 6 o'clock. This haptic comes out totally, to the extent that the entire haptic is outside, the leading haptic. It never slips inside.
But generally, what happens is when the trailing haptic is flexed and tried to take in, that is the time when the leading haptic comes out.
No.
So that is sometimes today also it happened to me.
Yeah, at that point, the surgeon, that is I'm holding that haptic, and then I'm flexing the trailing haptic. The moment I reach 6 o'clock, I leave my left hand. My left hand becomes totally free, and then I do the handshake technique for the trailing haptic.
Thank you. Exactly. That is what I needed to hear.
Yes.
Because till you get the trailing haptic in, the first haptic is being held with your left hand till you leave that one. That is
that's right. That's right. Yeah. This makes it totally surgeon dependent. You are not dependent on anybody to hold that haptic for you.
Anything else, Dr. Anand? Anybody to add? Shall we go on to our next speaker?
Yeah, I just have one small, comment. I mean, this is great that you need to hold your the leading haptic with one hand and with the left hand, the non-dominant hand, and insert with the dominant hand. But if you were to, insert, if you are using a tuck alongside a glue, if you were to insert it into that tunnel, then you're safe, you're stable. You don't really, even your left hand doesn't need to be coming to play. So if you just insert it very well into your, the intrascleral tunnel, then that tunnel is grabbing and holding that haptic. And then you can maneuver, you have little more license and degree of freedom to play with your trailing haptic. So that's the only point I'd like to say. But
One minute. You mean to say that when you're externalizing the leading haptic, you have to tuck it and then go ahead and do the trailing haptic.
Exactly. That is how Sharior Gabor described his initial thing. So it's the same point I was making with when Ashay was describing. Very often what happens is when you have both the haptics popped out, one haptic tends to go in. And like Minu was saying, it's when you're doing this internal movement with the trailing haptic, the other external haptic, the one which is already outside, tends to slowly drip in. And then you're ending, either you or the assistant is kind of grabbing that. So what I usually suggest with this is that put it in. And I have a small modification, if I can digress for a few seconds, is that what I do is when I make my scleral intrascleral tunnels, I use I go with a AC the paracentrus needle and make it wider at the limbal points and make it taper towards the end. So they're actually right angle tunnels. So why I do that is, so you can, at the point of entry of those tunnels, when you're grabbing the haptic, you can use a McPherson, so that wide little, maybe 3 millimeter wide tunnel accommodates your McPherson and the haptic. And then your McPherson is just continuously pushing that haptic into the tunnel, and it's becoming narrow and it's grabbing it there. After that, it's actually very difficult to dislodge that haptic off the tunnel because it's so narrow. So you got at least 3 to 4 millimeters inside.
What I often do is that, when you have externalized that haptic, you can also take a 26 gauge needle and come from the opposite side, and you can just thread it and it just comes and it just goes off. I mean, there is no.
I agree. That
no passage to create it.
Perfectly, I agree. But for me, that there are little too many more ports into that.
I think there are many ways of doing it.
There are different ways of skinning a cat.
No, yeah, it's just that you do what's good in your hands. Yes.
What I'm trying to suggest is a minimal invasive method.
Yes, Dr. Naren.
Yes. So I just want to, I mean, I completely agree with everyone. See, eventually it is the surgeon. What technique works in his hands might not work with someone else's hand. So you really need to optimize, I mean, try everything and then finally stick to something and keep repeating so you become really good at it. And just to make a point that, let's say if you're one of the surgeons where always one of the haptics keeps slipping, or once you put one of the haptics and the trailing part, it just slips every time, the IOL goes down, you start manipulating too much in the chamber, and you don't want to do that. I mean, a simpler way is where you can have a scleral fixated IOL, where you can suture both ends outside the eye itself, and then what you can do is take each of these sutures and feed it, bring it out, because you can always keep the length which you're more comfortable in this particular scenario, and then you can use the same Yamanik technique where you can just cauterize the edges and then tuck it in. I mean, this is a little more easier for beginners where they find it more difficult to manipulate in the chamber. So you always have a longer length, and even if you miss it, the best part is you can always pull back the suture from the main port, and then you're good to go and you can restart it. This is a little more safer one for an amateur surgeon, I would say.
Ma'am, just a point to add. For my fellows, I always tell them to depend on anyone in a retina surgery is very scary. So at least I don't use any assistant, or I don't use a stopper also. You can have a paper stopper or a sponge stopper. My fellows, in the first few cases, the leading haptic, we insert a stopper so that it doesn't get internalized. So that is quite an easy technique to prevent it from slipping into the vitreous cavity.
Yeah, I would just like to take 30 seconds more. My colleague, Dr. Prabhu Bhaskaran, has brought out a technique called the XNet technique, in which that would be valuable to see here, in which it's something like a Yamane. It's bent, and he sweeps it from one side and externalizes it through the tunnel outside, and then introduces the haptic, the leading haptic, into the lumen of that needle, and then it comes out. And like Asha mentioned, there is a stopper, silicone stopper. So when it comes out, when he pulls it out, that leading haptic comes through that stopper. After that, there is absolutely no question of the leading haptic going down. And then, of course, the rest is done similarly on the other side without the stopper. So the stopper is on one side for the leading haptic, so that haptic does not get distortions. And this is something we use quite easily. And everybody can use different techniques, but the one which has the least chance of dropping down is possibly the technique that might need to be endorsed.
Okay, thank you. We should move on. We have thanks a lot, Priya, for your lovely talk. We now have Dr. Tamilarsi, who's a senior consultant cataract and IOL services from the Eye Foundation group of hospitals, and she's also a phaco trainer. And she's going to talk to us on iris clip IOLs. On to you, Dr. Tamil.
Thank you, ma'am, for this opportunity. My screen visible, ma'am? Is it visible?
Yeah.
Today, I'm going to talk about iris clip IOL. In eyes with insufficient capsular support, iris claw lens have been increasingly used by surgeons nowadays because it is a simple and fast technique, and it provides favorable functional visual outcomes. The sole prerequisite is aphakia with the availability of the iris tissue. The contraindications for iris claw lens would be a gross iris abnormalities like traumatic aniridia, or diffuse iris atrophy or chafing due to primary surgery, and presence of active iritis. In case we are planning an iris claw lens as a secondary procedure, we should evaluate the eye thoroughly, a careful slit lamp examination for corneal status, specifically the specular microscopy for corneal endothelial status, and look for the iris pattern and structure, and OCT for macular status, and complete peripheral retinal evaluation is essential. The iris claw lens which we use is a single piece all PMMA lens. It has two oval haptics with a split in the middle to form a pincer or claw-like mechanism in which we use to fixate the lens to the iris tissue. The lens can be implanted horizontally, vertically, or obliquely to suit any clinical situation. There are multiple options available, and what we use is from Excel Optics, no financial interest. And the A constant of this is 117.2, which is used for IOL power calculation. The point to note here, it is not a foldable lens. So the optic size is 5.5 and hence it demands an incision of 5.5, and it also depends upon the primary indication. Here to the left is a case where the patient had a grossly subluxated hard cataract due to pseudoexfoliation. So the primary thing is to extract the whole nucleus. So I'm making a large sclerocorneal tunnel. And to the right is aphakia due to a complicated cataract surgery. So the incision size here is going to be 5.5, either a scleral or a clear corneal incision. But in case we are going to implant the iris claw due to a complicated phaco case, we would have done a temporal clear corneal incision. So we have an option of making a 5.5 temporal sclerocorneal or superior sclerocorneal incision. Or else what we can do is just make a posterior scleral side cuts to the existing clear corneal incision and fashion a tunnel. This would avoid from enlarging the existing CC clear corneal incision, and hence the wound-related problems like delayed wound healing and increased magnitude of surgically induced astigmatism. Before implanting the lens, a thorough bimanual anterior vitrectomy is indicated. The use of tricot is also recommended. The pupil must be round, and it should be totally free of vitreous, nucleus, and the cortical matter. For the enclavation, what we need is two side ports, which is approximately 180-degree opposite. Here, I made a superior sclerocorneal tunnel. So I made side port at 3 and 9 o'clock limbus. And for enclavation, what we use is the iris claw holding forceps. We can even use normal lens holding forceps. And first is to place the lens horizontally over the iris center, the optic centered on the pupil. Next, we have to hold the lens until one of the haptic below the iris. Once it is tilted, lift the haptic so that we can see an inundation of the point so that we can enclavate using the spatula. Once this is done, we can also confirm it by pulling it We can confirm it by just pulling it posteriorly, where we can see that the iris tissue is enclaved. And once one site is enclaved, then we can remove the forceps, fill it with viscoelastic, and then hold it again and repeat the process, the same process on the other side. You can either retract the iris and take the haptic behind, or tilt it and enclavate. Less pressure should be exerted while enclavation. This is to avoid damage to the iris, prevent any holes, or even damage to the haptic itself. Finally, the presence of two dimples in the iris confirms that the two haptics are enclaved. This is the same postoperative picture of the patient which I showed. The pupillary distortion can happen if there is an asymmetric fixation of the haptics or too much volume of iris tissue has been enclaved. And also the site of enclavation, if it is too close to the pupillary margin, it can cause pupillary ovalization. And when clipped to the mid-peripheral portion of the iris, the dilatation is not at all hampered, and we can achieve the pupillary dilatation, which is there in the preoperative period. And need for PI is controversial. If you have done an adequate vitrectomy, the peripheral iridectomy can be avoided. And PI can be done even using a vitrector using the IAC mode. The concerns of iris clip IOL or increased intraocular pressure, and studies have shown it is very transient. And this is attributed to the presence of residual viscoelastic. So always make sure we thoroughly wash the anterior chamber of viscoelastic. And the second cause of increased IOP is inflammation. So make sure that we treat the patient thoroughly with steroids and NSAIDs in the postoperative period, and check the IOP and peripheral retina at 2 weeks. Another concern is we are placing this iris claw lens in an eye which has undergone a complicated cataract surgery. So the risk of CMA should always be kept in mind and treated. This is a case of a complicated cataract surgery where the primary surgeon has done a large PA. It has led to an iris defect. So in such case, the area of enclavation should be chosen to be away from this site, and plan your main incision and side ports accordingly so that the the iris claw lens can be adequately enclaved in the remaining site. So to conclude, the choice of secondary IOL is dependent on two major factors. One is the primary status of the eye and also the surgeon's experience. Thank you. And I also take this opportunity to invite you all to phaco refractive decoder 2, which is being held in Coimbatore on April 1st and 2nd. Thank you.
Thanks, Tamil, for a very detailed talk. It actually sort of took away all those tiny questions which I had kept for you. But just one thing, supposing the haptic has got disenclavated, how would you re-enclavate it?
First of all, ma'am, you have to look for the cause of haptic disenclavation. If it is due to an inadequate capture of the iris tissue, we can go and re-enclavate. And at the time of re-enclavation, we should always make sure that we look at the site of enclavation, whether there is an iris, either iris atrophy or damage to the iris at that site. If so, we have to avoid that site of enclavation, and also look for damage to the iris haptics. If there is any damage to the haptic, the claw, then we have to replace the iris.
Yeah, right. And how would you re-enclavate it? Or rather, what I'm trying to ask is how would you disenclavate it if you want to disenclavate?
Disenclavation, we have to hold the IOL optic with a forceps and then gently pull the pinch which is seen in the iris. Sometimes we have to go beneath the iris also and have to release the site of enclavation.
Right, thank you. Anything else? Yes, Dr. Aniruddha? Yes, Dr. Aniruddha, could you take your question?
I think when it is when you need to disenclave intraoperatively, it is fine. But if there is a dislodgement of this iris claw, one side, and later on we need to actually, if you see that claw is damaged, and we need to take out this lens and put a fresh one, to disenclave that attached iris claw is very difficult. And at times it's like you need to cut that iris tissue and take out the lens. I think that's a difficult part of this lens.
Yes, sir, I totally agree with that, because once it gets stuck to the iris tissue, it passes through that iris tissue sometimes. So disenclaving from that merely might need to, cutting a little bit of a part of the iris. That is one difficult part of that. My second question, Dr. Tamilasi, that's a very good video. How you tips for the people to tell how you avoid peaking of this pupil? The most common immediate complication post this iris claw is the peaking of the pupil, and how do you avoid it? And what cases of pupil, they say it's a temporary effect for a few days and then later. So in what extent of the pupil is considered temporary effect and what is not considered and will remain for long?
To answer your first question, the ovalization or the peaking of the pupil happens if you are enclavating too much of an iris tissue. And the site of enclavation is also important. If you are enclavating too close to the pupillary margin, then we are going to have this ovalization. So always enclavate in the mid-peripheral part of the iris, which is immobile. And your second question, I didn't get it. Can you repeat it?
Some authors say that this peaking effect is temporary. And then over the days, sometimes it goes off. And the other question is, do you enclave it on the same side, or some surgeons use the opposite side of the side port to enclave it? So which one do you think would be better? Of course, the easier one would be enclaving on the same side. But I have seen many surgeons going from the opposite end and trying to enclave it.
Same site would be ideal.
Yes.
Same site would be ideal, Srinivas. It goes without saying. And what was the earlier question you asked?
Why they prefer opposite side is because they say that they can see pretty well on the same side. Sometimes you might go too near to the pupillary border, or you might go far away. And the judgment might go wrong if you do on the same side. But on the opposite side, few authors, they argue that you have a good control.
And the other thing is, peaking is not temporary. Peaking on the table, if you see, it's going to stay peak forever. So you have to tuck in the right amount of tissue, and it should not be too close to the pupillary margin. It should be midway. And the volume of tissue which is tucked in should also be similar. If it is peaked in the beginning, I do not see any ways that is going to become all right over the period.
Madam, if we put pilocarpine and do the enclaving, then we will have a ovalization on table, but later on this will be corrected. Rather, I have been doing this procedure for 8-9 years. It is always advisable to do it in a mid-dilated pupil, where we can actually appreciate the dimple instead of making a Myers pupil where it is done more blindly.
Exactly. That was what I was expecting. Thank you, Anirudh sir. Kiranjit sir,
I
I
just
think they have
have one
done
comment.
huge number of IOLs. Yes, Kiranjit sir, and then Sri Ganesh sir.
So I have 2 points to tell you. One is for the beginners, because the beginners fear that the lens may fall down into the vitreous when they are doing the first or the second case. So easy tip for them is to pass a suture through one of the claws and go behind the iris and enclave the iris downwards into the claw. So in case the lens slips from their hand, you can always pull the lens into the pupillary area again by pulling the thread. So this is one tip. Other tip regarding the peaking is, if you have a big lens, 8.5 millimeters or 8.2 millimeters, you are bound to enclave the iris which is on the pupillary side. You will enclave like this. So when you enclave like this, it will have peaking effect. And if you have a smaller lens which goes up to the mid periphery, you can enclave the iris downwards like this, or from the periphery inwards. So then peaking doesn't happen. So these are the two. Always have custom fitted. For you can have bigger lens. For the smaller eye, you can have a smaller lens.
Thank you, sir. Very important practical tips. Yes, Sri Ganesh sir.
I just wanted to talk about my technique of disenclavation, because disenclavation is always a challenge. And when you try to disenclavate, suppose you have not fixed it in the proper place and you have ovalization of the pupil, you want to disenclavate, it is very difficult. And many a time, if you try to disenclavate, what will happen is you're going to damage the iris tissue. You'll get a hole there or a tear. You can also end up with an iododialysis. So my technique for disenclavation of an already enclavated lens, you dilate the pupil fully. Once you dilate the pupil, then you go in and hold the haptic through a side port with cannulated forceps, and use the thick scissor from Katina from the main incision and cut it at the optic haptic junction. Okay, once you cut one haptic, then it will get released. There is a chance that the IOL can tilt or drop, but don't worry, it will be held by the other side. After you do this, you bring out that piece, then you hold the lens and put it on top of the iris. The area which you have the disenclavated, the haptic, you put it on top of the iris so that it does not fall down. Go to the other side, do the same thing, and then you can bring out the lens. In this way, you will avoid any iris damage. So once you cut the haptic, then it is free. If you try to disenclavate the claw, that is when you're going to have problems like iris tear and iododialysis.
Quick last comment from Dr. Ashray, and then we can move to the next.
Sir, in 1971, when Wurst et al. Described this technique, it did serve us really well for 2-3 decades. But I strongly feel on table, if there is a problem, you can still resort to this technique if there is no access to VR surgeon. But distorting an anatomy and having an elective insertion of iris clip IOL can be lead to long-term consequences. So I would strongly, I'm strongly against this procedure. But anyways, certain times people resort to.
Srinivas, can I ask one technical doubt in this? Paracentesis, when you make, Tamilarisi, you could please explain. Paracentesis, when you make, if you make it more into the cornea and then introducing a needle, or going backwards towards the limbus and making a stab entry, which will be parallel to the iris, which will be easier to do the tucking. As sir was telling regarding the direction of tucking backwards like this and straight like this. So if through the cornea, if you go down and then turn downwards, the tendency to tuck will be backwards like this. But if you are at the limbus, you can go straight and then tuck down straight like this. I'm not too experienced with this. I'm just asking a logical doubt.
Yes, sir. Should be a stab, more limbal, sir.
In stab distribution, I think I should have had equal distribution of anterior segment surgeons and posterior segment surgeons when we do talk of iris clip lens. So we close
Dr.
this chapter.
has asked a question where he himself has answered that question. So
nothing like that. Ashray talks like a vitreoretina surgeon. So anterior segment surgeons are happy with the way they are doing. So I will deal with him tomorrow. So we go on to our next speaker, Dr. Vivekanand. V.R. Vivekanand, who is again a medical consultant and intraocular lens and cataract services based at Arvind Eye Hospital, Pondicherry. And he's going to show his innovative technique of iris fixated IOLs. On to you, Dr. Vivekanand.
Yeah. Good evening, everyone. Just 1 second, madam. So good evening, everyone. Today I'll be talking about aphakia management in our practice, mainly about iris fixated intraocular lenses. So the main indications for doing this technique is when there is insufficient capsule zonular support, late in the back dislocation of PC IOL and primary IOL opacification. This procedure can be done provided the iris tissue is healthy and round. No. So contraindication, gross iris abnormalities such as aniridia, diffuse iris atrophy, multiple sphincterotomies, chronic uveitis history, hazy corneas. This technique will not be a good option. So usually a multi-piece lens, a 3-piece PMMA or a foldable 3-piece lens can be used to do this technique. It can be done as both single haptic and double haptic technique. So single haptic, if you have partial capsular support, one haptic can be placed in the sulcus and the other haptic can be fixed to the iris. In case of no support at all, double haptic fixation can be done. So for this, we need a long curved needle attached to a 9-0 Prolene suture. A bite is taken at the limbus, passes through the mid-periphery of the iris, not close to the equator nor the pupillary margin, somewhere in the middle. It goes underneath the iris and the needle is tilted so that it passes out at a mid-periphery of the opposite side in the iris and through the limbus on the other side. So this video and image is for a single haptic fixation, just to have better understanding. So there is a loop of suture underneath the iris tissue here. No. So exactly right in between the two suture points on the iris, a paracentis is made. This is made mainly to facilitate tying of the suture knot so that it falls on the iris rather than on the cornea. So once the paracentis is done, using a Kuglen hook, the iris is depressed at the site where the bite has been taken, and the underlying suture is exteriorized through the sclerocorneal tunnel as shown in the image. Now we have a loop of suture, Prolene suture, outside the eye. So this suture loop is looped around the haptic, which is intended to be fixed a couple of times. I prefer to do it 4 to 6 times, and the loop is pushed to the optic haptic junction. It is pushed towards the optic haptic junction in order to prevent slippage of the loops. So after this, in this particular case, the right side had capsular support. So the leading haptic is placed in the sulcus, and the trailing haptic is the haptic is held. It is pronated and then released underneath the iris, simultaneously pulling the sutures on the exterior. This is mainly to keep the loops taut at the optic haptic junction. It is very important to note that we should not dial the intraocular lens in such a scenario, because when you dial, the loops tend to slip off from the haptic and there is a chance of IOL slippage. So once this part is done, the exterior suture coming out of the corneal ports, two corneal side at the limbus, is trimmed to about 1 centimeter on both the sides, and it is interiorized using a spatula or a Kuglen hook. So now we have both the sutures inside the anterior chamber. So using a Kuglen hook through the common paracentesis, both the sutures are exteriorized through it.
Shesh, you want to go next?
So similarly, the second suture is also exteriorized using the Kuglen hook. So as shown in the image, now we have both the sutures coming out of the common paracentesis.
Okay. Yeah,
so after this step, the suture is tied. So I prefer to do a 3-1-1. So this is, it is very difficult to quantify how much tightness you should do, because the depth of the iris and the paracentesis are at different planes. So with a lot of cases being done, we can do this, but make sure not to keep the sutures so tight on the iris. No, the sutures have to be loose over the iris, so that if it is tight, you're going to see a tilt. The IOL is going to tilt upwards. So it has to be a little loose so that it is at the plane of the posterior capsule. This also, later on postoperatively, pupillary movement is not restricted when the sutures are a little bit looser. If it is going to crush the iris, you're going to have iritis, you're going to have iris atrophy is going to happen, and pupillary reaction will also be affected, and peaking can also happen. So following this, so the problem of doing anterior vitrectomy before doing this is the eye becomes really soft and it is difficult to take the bite. That is one problem. And the second problem of doing anterior vitrectomy after placing the intraocular lens is there is a high chance you can cut the suture accidentally. So you have to be very careful while doing anterior vitrectomy after placing the intraocular lens and placing the sutures. Make sure you do not go close to the suture area. So it can be done as a double haptic technique also, as in this video, where the nucleus is extracted. The curved needle is passed on both sides, and in a similar fashion, the suture loops are brought outside. Both the loops are from either side is brought outside, and the left loop is for the trailing haptic and the right loop is for the leading haptic. Multiple loops are placed, and then the IOL is placed behind the iris. And in a similar fashion, the sutures are trimmed, interiorized into the anterior chamber, and then brought out through the paracentesis made on either side, and the knots are placed. So the post-op pictures are, these are a few post-op pictures. It can be really nice. The post-ops will be quiet because it is not going to touch the iris. Very minimal iritis and inflammation will be there. So the advantages, it provides good stability to the IOL, no suture-related complications such as breakage or exposure. It is a cost-effective procedure where regular PMMA lens and a suture is all what you need to do this technique. But disadvantages, it is a very complex procedure. It is very difficult to teach residents and fellows how to do this. It has a long learning curve, a lot of practice is required. And decentration and tilt of the IOL can happen in any case, and for anybody. For an experienced surgeon, this can happen very often because it's very, very difficult. Sometimes if the cornea is hazy due to prolonged surgery or something, this can happen. It can be done both as primary and secondary procedure. So, but we do not do this technique very often, but this is one indication where we do, where there is a decentered IOL with strong capsular and bag complex in certain areas. In this particular case, meiosis is, mechanical meiosis is done. And using a vitrectomy probe, the posterior capsular opacification is cut so as to clear the pupillary area. And a blind bite is taken so that you go underneath the haptic. The sutures are lifted, and if the IOL lifts along with it, you know that it has gone underneath. So this is one indication where we use it right now. The problem is that there is no looping around the haptic. It is just one swing of suture. In similar fashion, it is done. So the main problem with this is the tilt, so I'll just share a small video of a new technique that we are doing right now. So this is a modification of Yamane and Canabrava's technique, a simplification, I would say. The cataract is removed, but it requires a sclerocorneal tunnel. So we've designed a spatulated needle, which is attached to a 7/0 proline suture. A sclerotomy is done on one side, and 6 clock hours away from it, the second sclerotomy is done using a different needle and the same suture. Using an AC maintainer through the tunnel, the needles are exteriorized. The needles are trimmed, and using a regular PMMA lens, the sutures are passed from above to below, and the sutures are flanged using low power cautery till the flange is larger than the dialing hole itself. And the exterior sutures are trimmed to about 1.5 millimeters. It is flanged, buried underneath the conjunctiva. So in this, what we do is we keep one site closer to the sclerocorneal tunnel so that it is not going to be difficult to bury the second flange. All we have to do is close the peritum. So thank you, Chitra Madam and ARC, for giving me this opportunity.
Brilliant surgeries, very innovative and nice. Vivekanand, supposing a person had You needed to do a pupilloplasty along with iris fixation. That's possible, or there are certain clues to be given in that.
Which one, madam?
There's some amount of iris damage. You need to do a pupilloplasty also, and you have done the iris fixation. Is there anything of a challenge in that?
Yes, madam. If the sphincterotomies are large or if the iris tissue is a little weaker, it is better to avoid this technique, madam. We need really healthy iris, and we should not be close to the pupillary margin or the equator. Somewhere in the mid-periphery, if it is healthy, and if the multiple sphincterotomies that residents do is smaller, we can still do this technique.
Anything else, Srinivas?
Dr. Vivekanand sir, very nice and innovative videos. But I'm little interested about your last video which you showed. It was a 6-O-proline which you cut and did a flange.
It's a 7-0-proline suture, sir.
7-0-proline, because what was described by Sergio Canabrava, it's almost similar. But why don't you use the SFIOL itself instead of using the dialing hook of that IOL? Even the SFIOL has the eyelet, and
Yes.
you can use the eyelet of that SFIOL and then try to flange it. So what difference? Have you tried this technique and
Yes.
that technique? Because this
Yes.
technique looks very interesting for me. I've never tried
Yes.
this.
Yes, sir. I have tried both. The problem with the other, it's not a problem. One, the first reason is you have to have a big library of lenses, in the training institute where it is available, but for individual practitioners, it might not be available. For regular PMMA lens will be easily available to everybody. And most of the SICA surgeons have these lenses in their inventory, and most of them have dialing holes as well. The second point is the haptic being a very flexible material. If you flange a little tight on the other side, you try to compensate for centration on the opposite side. So when you pull, that can cause a little bit of tilt. So whereas the optic, it'll be a little decentered if you're flanging too much on the first side, but the IOL will still be stable and there will not be any tilt. Now optics, because they're not flexible, they're going to be rigid. They don't tend to the external pressure.
And did you find any difference between the 6-O-proline and the 7-O-proline, sir? Why 7-O-proline?
Yes,
Because
so we have tried.
It's always better.
Yes, we tried the 5-0-proline first. We've been doing this for past 2 years. We've actually incrementally made some changes. So 5-0, 6-0, and then 7-0. So we did a few lab tests to check the strength of the suture compared to the flange, knots with the flange with all 3 sutures. And this is on par with the 6-0-proline, not on par with 5-0, but it is closer to the 6-0-proline suture. And one thing we wanted to reduce the size of the sclerotomy. So that is one reason why we designed this suture material with a spatulated needle. So the needle dimension is around 150 microns, and the dimension of the incision that it makes is around 200 by 100. That's the dimension. Whereas when we use a 26 gauge or 30 gauge, it's a little bit larger. It is a circular sclerotomy around 400 microns, around 340 to 400 microns.
And you did it under the flap? No.
Not under the flap. No.
Then how are you going to prevent the conjunctival erosion? Because since you're using a direct entry and it's not a Z-track entry and you're not pushing that flange back into the scleral tunnel, then that bulb is going to be exposed.
Yes, so the first thing, if you had seen in the video, sir, we moved the conjunctiva radially. Conjunctiva being a tissue which moves only radially. We displace the conjunctiva radially. We position the needle at the place where we want to make the sclerotomy. Hold the conjunctiva there, move it radially by 2 millimeters and make the sclerotomy. So that at the end of surgery, we have an intact conjunctiva over the flanges. And to prevent flange erosion or conjunctival erosion because of large flanges, that is why we've designed the spatulated needle. So the amount of suture required for flanging is less than 1.5 millimeters when we use the spatulated needle. But when we use a larger needle, a 30 gauge or a 26 gauge, we have to flange about 3.5 millimeters of suture, which causes a very large flange. So this is like a very small dot. And you do not see any elevation in the tear film. And we've done over 250 cases so far. And we've trained a few doctors across our centers, and the results are fantastic. Initially, when we were doing the 30 gauge technique, we did have a few cases where conjunctival erosion happened. But with this new sutures and needle combination that we are using, we've not had any. We've done around probably 180 cases with this new suture needle combo, and everything is fine so far.
Fantastic.
Thank you. Thank you, Vivekanand.
Okay, when I ask Madam Vivek, which company makes the bent needle Prolene suture? Is it Orolab?
Yes, sir. We Orolab makes that also.
Because I don't think it is really available. We are always getting straight needles. The long curved needle, it's there in Orolab.
Yes, we should ask for long curved needle, sir, because they have a short curved needle for the sutured SFIOL. So the long curved needle is there. It is there in the market.
Okay. Thank you.
There's going to be a small change in the sequence. Shreyas has to start traveling from Cochin now, so the network would go. So he's going to present his case. And Shreyas is a consultant cataract, cornea, and refractive services at the Eye Foundation Group of Hospitals based at Coimbatore. And he's going to be talking on aphakia with corneal decompensation, my approach. On to you, Shreyas.
Yes, you need to unmute yourself.
Hear me now?
Yeah, we are able to hear you.
Increase your volume.
Good evening, everyone, and thank you for accommodating me. So the entire session being about aphakias and secondary IOLs, it's easy for most cataract surgeons to forget about the cornea. And very often we are faced with difficult situations where the patient, nowadays, if the patient has an aphakia, is usually because of a very complicated or badly done cataract surgery, which can result in aphakia concomitant with decompensation as well. So how do we go about addressing them? Now, with the advent of endothelial keratoplasty, DSEC or DMEC remains the option of choice to avoid all sutures and to combine it with a secondary IOL. But one of the challenges in these aphakic patients is a sufficient airfill or a tight airfill is an essential prerequisite for successful outcome. And this may be difficult to achieve in aphakic eyes or eyes which may have also been partly or completely vitrectomized. And some of these patients may also have concomitant glaucoma, which also complicates things. So I will now go on to talk about just three different approaches. Showing three examples, one with an AC IOL and a scleral fixation, and then a retro-iris fixation combined with endothelial keratoplasty. So in this kind of situation, where you see a very large iris defect with a subluxated lens, in these cases, it can be quite challenging. The visibility is quite poor to do a good scleral fixated lens. So in these cases, what I'm trying to do is since this being a rigid PMMA IOL, which is subluxated, this is being removed out through a large sclerocorneal incision. And then subsequently, after doing a thorough anterior vitrectomy, an anterior chamber IOL can be used. Now, this is an eye where the iris support is less. So doing an iris fixated lens would be not very easy. The visibility is a little poor for a scleral fixated IOL, but the anterior chamber is very, very deep. So being a deep anterior chamber, I can go ahead with an AC IOL. Studies have shown even 5-year outcomes of an endothelial keratoplasty combined with an AC IOL are similar to that of a scleral fixated IOL. So as long as the anterior chamber IOL is properly sized and placed at a sufficiently deep position with the anterior chamber being fairly deep, you can combine these with endothelial keratoplasty as well. Also, additionally, the AC IOL, as you will see now, will provide a scaffold for the IOL, for the bubble to be retained above the IOL. So this is very, very important and is essential for the successful outcome of the procedure. Yes, some air may escape into the posterior chamber, but then because of the large surface area of the haptic and the optic of the AC IOL, most of the air bubble is retained in the anterior chamber, and you can get a tight fill and do a successful surgery in these cases as well. Here's another case where the visibility is even poorer than what it was in the previous case. But fortunately, we have sufficient iris tissue. Yes, it is a little atrophic in certain patches, but you still have sufficient iris tissue, which was not there because of a large sector iridectomy in the previous case. Again, doing a good anterior vitrectomy before you go ahead with any maneuver for the secondary IOL or the DSEC is extremely important, because the air bubble will not get retained even if there is a little bit of vitreous in the anterior chamber. Here I'm using an iris clip lens, and if you have sufficient iris tissue, it's a very easy, quick procedure to do. You can do with a scleral or a clear corneal incision, and it's just a 4.5 mm incision that you require. And then after you've adequately enclavated it, you can then go ahead with a DSEC. I perform PKs as well as DSEC with the iris clip lens. One concern could be whether the enclavation can get loosened when you do a tight fill. But fortunately, once it's properly enclavated, it's very, very strong. And even with a tight anterior chamber fill, which you require for your DSEC, this IOL remains extremely stable. The third and final example I'm going to show is a patient with a vitrectomized eye. It's a one-eyed patient with a glaucoma in the inferior aspect. The cornea is decompensated superior to it. Now, there is a significant amount of peripheral anterior synechia as well. So I don't want to attempt any anterior chamber or an iris fixated IOL. And this would be a good case for doing a scleral fixated IOL. And the visibility is also reasonably good. But one thing we must remember is to always start an anterior chamber maintainer or put in a pars plana infusion cannula before you start, because in these eyes, if you don't know whether they are vitrectomized or not, they can collapse quite significantly. Well, once you have the infusion in place, the globe is maintained, and then you can do whichever SFIOL technique you're comfortable with. This is a simple sutureless SFIOL technique like the XNet procedure, where you can go ahead and pull out both the haptics and tuck them into the flange or the tunnel that has been created. And as such, no glue or suture is required. And you can then go ahead and do the DSEC procedure. Now, again, here the SFIOL will provide a scaffold. The air bubble maintenance can be challenging. Air will go into the posterior segment, as you can see here. So maintaining an adequate balance of saline with air to ensure that the anterior chamber is maintained so that it doesn't push or tent up the IOL and the iris forward. So having a sufficient amount of saline, not overfilling the eye with only with air, infuse saline into the posterior segment and then have a tight fill. You will have some bubble behind the IOL as well, but that's completely all right. Go ahead and suture the sclerotomy port, and then with a tight fill, you can have good outcome even in these difficult situations. So you can have any choice of IOL depending upon the situation, as you just saw. Sometimes you could just do an aphakic DSEC if the other eye is also aphakic with the clear cornea. You may, however, require a hitch suture because the air bubble may not retain for long enough and may escape into the posterior segment, and therefore a hitch suture may be required. Thank you so much for your kind attention.
Just one question. Normally in an iris clip lens, if you have done a good vitrectomy, you don't need to do a PI. But I think when you're combining it with a DSEC, with an air fill, you need to do a PI for all cases, right?
I generally do a PI in all these cases and like to leave them with a tight fill, especially in these aphakic eyes, partly vitrectomized eyes, and the secondary IOLs. It's difficult to get a good tight fill in these eyes. So you would want to leave the patient with 100% air fill. And so I will always do an inferior PI in all my, in such cases.
Yeah. Any other question from the other expert panel? Dr. Anand? Dr. Aniruddha, you have anything to ask before Shresh would start traveling? Dr. Naren, would you want to ask him anything?
Nothing actually. Completely. Shreyas has done, I mean, a wonderful, set of surgeries and videos. He's shown every technique is if done properly, because some of the IOLs have got a bad name. That is because of the initial bad handling, to handle the PCR or the dislocated lens, all those things. What happens is they would have handled very badly and then placed an AC IOL, and the AC IOL got a very bad name after that. But like you said, I completely agree. Properly sized AC IOL does pretty well.
Yes, truly, very rightly said. That is why I had wanted Meenu Mathan's talk to come in between to give clarity on the reasons why AC IOLs failed at a couple of decades back. Thank you very much, Shreyas, because you answered all the questions which could have been posed for you. We go on to our next speaker, Dr. Dr. Nivian, who is one of the directors for academics of MNI Hospital based at Chennai, a very innovative surgeon, and has won quite a few of those Think Another Apple Tree Awards, and I'm sure many more. And he would be talking on a newer innovative approach to secondary SFIOLs, his technique.
Thank you, ma'am. Is my screen visible?
Yeah.
Respected teachers, senior ophthalmologists, my dear friends. So I'm going to talk about the new innovation, the CMT Flex IOL, a new option for aphakia. I do not have any financial interest. As you all know, all inventions come with the question why, so did mine. So we have seen all the techniques that have started 3 days before the sutured technique, and then Gabor Shariat's doing the externalization of the haptics and various modifications of the technique, like the blue diode technique, and then the X-Nick technique, and then the Yamane technique. But then they were all the 3-piece IOLs. So we came up with the design. Why not have a specific design for this type of aphakia? So that gave birth to the CMT Flex IOL, which is a single piece hydrophilic design, as you can see here, with specialized T-shaped haptics on either side. So these T-shaped haptics, when brought out of the sclerostomy, opens up and prevents it from falling back. So let me just go through 2 case scenarios. So here we have a case which had an aphakia post phacoemulsification. We all know that for any secondary IOL, 0-180 degree is very important. One for the stability and for the astigmatism. So once we make a 2 by 2.5 partial thickness flaps on either side, 1.5 millimeters away from the limbus, we make a 23 gauge sclerostomy. So then after doing an anterior vitrectomy, we have the specialized T-flex forceps, and this can be done through a clear corneal incision and loading it into any normal cartridge. You can see the T haptics coming out first. So it is easy if you grab it head on. You can actually hold the neck also or the tip, but head on position, as you can see here, is the ideal position, because when the T shapes comes out of the sclerostomy, it opens up and pops out. And then now inject the lens, because it's a single piece lens. Don't pull it right now, because that can detach it from the optic. So inject the remaining lens, leave the trailing haptic over the iris or at the wound, and then slowly pull it out. And then you can see there the T opens up. And because of the haptic design, it just sits there. This is just a short animation clip showing that it can be done into any regular IOL cartridge. And just make sure the T haptics comes out first so that it makes it easier to grasp. And then at the sclerostomy, just pull it out gently. For the other side, we use the handshake technique. You can hold the arms of these IOLs and then transfer it to the other sclerostomy. Here again, head on is the ideal position, as you can see here. And at the sclera, you might have a slight tug, as you can see here. So at that point, we should be careful we do not release the forceps. And then once you see the T pop out, and then you can leave it. You can see now the T junctions on either side. So that is the end of the surgery. So it avoids actually tucking or suturing. Closing the flaps can be done through glue, as you can see in this case, or you can just suture it, or you can even cauterize it. Because of the haptic size, there is no leakage from the sclerostomy. So that is the reason why you don't have to actually close it. So this is the immediate post-op day 1 pictures, and these are some of the 1 month post-op pictures. You can see clear corneas, round pupils. We also done studies of the follow-up of the patients with UBM to see the position of the lens, where it sits comparing to the normal anatomy, and also OCT through the sclera to just see if there's going to be any long-term exposure of these haptics over the scleral bed. So as of now, we have a 3-year follow-up of the patients and also some publications. Just the long-term publications alone, we are just waiting for the final results. So this can be done by even anterior segment surgeons. The only thing is I always prefer to use a trocar, but you can also use an AC maintainer. So here again, you can see a case of a small incision which has had an aphakia. So we are not opening up that section. So the other advantage is it can be done through a clear corneal incision. Here again, just holding the T haptics and then injecting the remaining of the lens. Just make sure you have a firm grip. And once the rest of the lens is injected, in this particular case, now we are slowly modifying the techniques of making the full flap. We're just making a partial groove, because all we want is the T-shaped haptics to be under the scleral flap. So we don't have to make a full thickness flaps also nowadays. So we're just modifying the technique. You can see the T haptics out there. And then again to the other side. As you all previously, even Vivek has said that the main thing is the hypotony. So make sure we don't get any hypotony in these eyes because that can complicate any secondary IOL procedures. So ideal is to use an AC maintainer or a trocar, 23 gauge trocar. And then the other haptics are also pulled out gently. So once it is out, the lens is in position. The arms are basically for the stretching factor. So here again, for any secondary IOLs, make sure there is no vitreous. So this is just because we did the anterior approach, just putting in tricot and then washing it away, just to check there is no vitreous in the anterior chamber. So here again, because of the lens design, it can be used where there is iris deficiencies or even in patients who had traumas. So complications, just like any secondary IOLs, there can be breakage of the haptics or slippage when you pull the other side slightly forcefully. We haven't had any late dislocation as for the lens per se, but when you hold it through a sharper instrument, it can actually bite into the lens when you're trying to pull out. So that has caused breakage of the haptic later on. And exposure under the sclera, yes, if it is not fully covered, it can happen like any secondary IOL. And then, yes, it's been a long journey of 4 years from the drawing board to what it is clinically done. And because of the COVID, there was a delay in actually the patent and this thing coming out. So now it is actually patented and then it is done by Appasamy Associates. And now I'm just happy in the last 6 months, I think more than 150 people across have used it and given their feedbacks. And these are some of the publications that we have of the various local and the international journals. And we also taken it to the other countries also, just waiting for the legal issue so that it can be started using everywhere. So thank you. Thank you, Chitra ma'am and ARC for this, inviting me for the session.
Yeah, thanks a lot, Nivian. Just a question. I think like any of those other IOLs, just anterior vitrectomy should suffice, no, for these cases?
Yes, ma'am. Just anterior vitrectomy, or you can just go slightly deeper behind the iris. So make sure that there's no vitreous traction when you're actually pulling out these lenses. But it can be done through the anterior approach. So one side the infusion and the other side cutter through the side ports itself you can do. The other advantage, and this is because I'm making the sclerostomy 23 gauge. So sometimes I use the infusion in the side port and the 23 gauge cutter through these sclerostomies. So the same sclerostomies can be used to make the vitrectomy. That is actually a little safer because you're going near the pars plana and cutting the vitreous.
Okay. Do you have lenses in for high myopes also? These
right now only the standard powers are available, but they said they can customize it if there is any high powers. The only problem initially we had is any high axial length, the corneal diameter is very large because the overall size is 14 millimeters. In hypermetropes, you can make the sclerostomy slightly away. Instead of 1.5, you can even make it 2 millimeters and then do it. But if you have very large eyes, then I think you can go vertically. But I think right now we don't have a solution, but it can be customized is what they said.
Srinivas, you have any other question or anything?
Dr. Nivian, I think it's a wonderful thing which you have shown. It's a very innovative lens. Only few quick question is where you want us to hold the teeth, because some authors have said that while removing it, it breaks. It has broken in few hands. So where we should actually handle it and with what forceps? Because ILM forceps will be more damaging. The serrated forceps is what you recommend, or any other forceps for the anterior segment surgeons you recommend, and where should we hold it?
Good question. So we have a specialized T-shaped forceps called the Pranav T-flex forceps, which is just broad in the tip and slightly flat. So that is ideally to hold the head on actually. So when you hold it head on, you actually cover the T part, and when it comes out, it folds like this. So that way coming out through a 23 gauge sclerostomy makes it easier, and then it pops out. But you can hold the neck, but then there's a broader portion of the teeth that is actually coming out through the sclerostomy. So that is when you need to use little more force, and that time it can cut. As you said, the other VR forceps are slightly sharper. So because it's a hydrophilic material, it bites into the thing and slightly chips away the thing. And for the handshake thing, we also have some serrated forceps. So that because again, hydrophilic, those serrated forceps give you good grip and prevents it from slipping.
And can we use a max grip forceps for this?
Yes, sir. It can be done, sir. Definitely.
Yeah, maybe, sir. So I think that can be used.
But
the only thing is that
modified forceps. Where do we get this modified forceps?
The same Appasamy instruments itself. It comes as a kit actually. The CMT Flex kit is there. So they have both the instruments in the kit there. Now we just recently come up with a disposable forceps. So we are planning from this year, like it can come along with the IOL itself. So come out with the disposable.
That's better. because the max grip, if you use Mighty sir, is rich enough, he can use another forceps because it will, you cannot pull the membranes again with the same forceps one we use for that. I think doing it with the forceps, giving it with the lens, I think is a good idea.
Yeah, makes sense. Yeah. Thank you very much, Niven. We have many speakers, so we'll move on. Next is Dr. Sri Ganesh, who's the chairman and medical director of the Netradama Group of Hospitals. And he's going to show his new innovative approach to secondary SFIOs. On to you, Dr. Sri Ganesh.
Thank you, Dr. Chitra. I again have some problem. I'm not able to. Yeah, let me just bring up my.
Dr. Kiranjit, you can
Can
go.
you?
Okay.
Yeah, let me share my screen. At the outset, I would like to thank Dr. Chitra and the ARC for inviting me to this webinar, and I would like to share my technique of the modified four-flange technique. I am a consultant to Carl Zeiss and Biotech, and I have my lens, which I'm going to show you, and which I have a financial interest, and we have worldwide patents, and we are going to shortly commercialize it. So going on to the technique of the four-flange, in the four-flange technique procedure, it was described by Dr. Canabrava, and it's a no flap, no knots, no glue procedure. And then I modified this technique by using a preloaded needle, and I will show you the. Yeah, I'll show you my technique. The materials needed are calipers, 227 gauge needles. I use 6-O-Prolin, 2 strips 5 centimeters long, and the Scleral fixated IOL, PMMA IOL with eyelets. I now have my foldable lens, which I'll show you, and you need a thermal cautery. So this is, you just cut 2 strips about 5 centimeters long of 6-O-Prolin, pre-thread it into a 27 gauge needle. So that is threading the strips of prolene into the, and then 1.7 millimeters from the limbus, you just enter. Here I'm using an infusion cannula. I put in an infusion cannula. Once you do that, you can just push the prolene and it comes out. You hold it with a microforceps and bring it out through the scleral tunnel. The same thing is repeated on the other side, 180 degrees away. You pass this through the eyelet, and then you can flange it with the Bowie cautery so that the flange is inferiorly placed. And you can put in the IOL, and then once you flange it on both sides, you can see that it's perfectly centered. You just cut the prolene about 2 to 3 millimeters away, and then you can cauterize it and just push it under the conjunctiva, and that's the end of the procedure. I'll show you a few difficult cases. This was a case of a road traffic accident with a ruptured cornea, a spontaneous expulsion of the iris, the lens with a retinal detachment. Retinal detachment surgery was done, a tectonic graft was put in, and this was 6 months later. Later on, the patient came in for a secondary IOL. So I'm using the modified four-flange technique. You see, I'm passing the 6-O-Prolin, and then I use an aniridia lens with the eyelet, pass the prolene through the eyelet, and then flange it. The same thing is done for the other eyelet. Pass it in and flange it so that the flange is inferior. And after that, I release a few of the sutures. This is a very large lens. It's an 8 millimeter lens. Yeah, this was a very difficult case, very bad trauma. You can see that there's a total aniridia because the whole iris was detached and there was spontaneous expulsion of the lens. This was a tectonic graft. So I open the graft, and then I place the aniridia lens, and then I pull on the sutures, and then the lens gets centered. You'll have to hold it taut against the sclera. So you pull it, hold it taut. I hold it with a forceps, cut it, and then flange it. So it's tight against the sclera. That's very important. You should not leave it loose. And after that, you can just push it underneath the conjunctiva. And after that, we are going to replace this tectonic graft with an optical graft. And then you can see that the aniridia lens is sitting very well. That's the optical graft and suture at the air bubble. And this was the first day post-op. You can see that the lens is well centered and you can see the aniridia lens there. This patient has been followed up and doing quite well, has improved to a best corrected vision of 6/12. This was another interesting case, 14-year-old Marfan's syndrome with a subluxated lens. And if you look at the A scan, you can see that the patient has astigmatism of about 2.5 diopters. So here I'm using my lens, which I've designed, which is the swivel haptic IOL. And here this patient needs a toric lens. So that's the infusion cannula which goes in, and I'm using the Callisto eye there to mark the axis. I go and you can see the zonules. It's more than 180 degrees, almost 270 degrees of subluxation, and I do a capsulorhexis. These are patients, of course, you can use a CTR and CTS, but then it is a progressive subluxation, and after some years they come in. I do an eccentric rhexis, put in an iris hook, and then aspirate the soft lens matter. I then remove the whole bag. So that's the bag which I'm just kind of pulling out. It's only like 1/4 of the zonules are intact. And after that, I do a vitrectomy. And this is my lens. This is a swivel haptics lens. It's a foldable lens with two haptics which swivel, which are made of proprietary material, which have holes in the end. And you just inject it through a 2.8 mm incision into the antechamber. Rotate it. You can see it's a toric lens, so I place it as per the axis. And after that, I again put in this proline through a 27 gauge needle, introduce it through the hole of the swivel haptics, flange it, and then pull it. The other side also, we introduce the 27 gauge needle. The 27 gauge needle is introduced exactly perpendicular to the axis of placement of the toric lens. And that is the end of the procedure. I just flange the external part and then tuck it under the conjunctiva. And you can see that the axis also is fairly well placed along the Callisto, and it doesn't move or rotate. And this patient had an uncorrected vision of 6/9. So this is the swivel haptic IOL, which can be used for scleral fixation. So in our experience, we looked at it retrospectively, and with a modified four-flange technique, we have done 52 eyes, and mean age was 65 years. We have a follow-up of 1.5 years. And these were the indications: intraop PCR, Marfan syndrome, intraop ZD, subluxated IOL, trauma, dislocated IOLs. You can see at 18 months, the corrected distance vision was on an average 6/9.5, sphere 0.28. So the refractive predictability of this lens is very nice. Average cylinder was -1.25 because we didn't use a toric in all cases. The toric is just now, it's commercially not yet available, but we have started the trials. And this was the IOP, so we didn't have any patients with secondary glaucoma. These are clinical pictures, 6 months. You can see that, you can see the flanges there under the conjunctiva. This is the UBM. If you look at the UBM, it looks like a PCIOL in the bag. It's away from the iris. We have not had any scleral chaffing or pupillary block. We don't do an iridectomy. We have had one haptic slippage, one case of intraop tilt, and one haptic breakage. Haptic slippage, intraop IOL tilt was again because of the loose suture. So you have to pull the suture tight against the sclera and cauterize it so that the flange is flush. If it is loose, then you can have tilt and also flange exposure. We had hypotony in 2 cases, probably because of the scleral infusion wound, which was not sutured. We use a 25 gauge trocar cannula, but then it settled on its own. So to conclude, the four-flange technique of SFIOL is safe and effective, relatively easy to perform. Even our fellows perform it. Useful in hazy corneas because you don't have to do anything inside the eye. It's got a very short learning curve, and with the new foldable IOL, you can introduce this lens and do an SFIOL, even a toric SFIOL through a 2.8 mm incision and very clean surgery. Thank you very much for your attention. Any questions? Happy to take them.
Wonderful, wonderful technique. Srinivas, do you have any question to ask?
Sir, as usual, wonderful surgeries. It's really a treat watching your surgeries. But the only thing is, in that case, sir, what was the real use of the swivel? Because in the earlier, we thought that even the dialing hook also can be used to, hook that the 6-O-proline or the 7-O-proline. So I just wanted to know the usage of this swivel, what you are using. It looks
the swivel haptic lens basically is a lens for all conditions. So you can use it even in normal cases for toric IOLs. Basically, you're doing a capsulotomy fixated IOL, so there's no movement. It's excellent for toric IOLs, and you don't have any dysphotopsia. These are for normal cases. But suppose you have a PCR. Also a small PCR, you can still place the lens and then capture the swivel optics in the capsulotomy, and this lens is very stable and well centered. Suppose you have a zonulidescence or you want to use it for aphakia, then you can use this technique of scleral fixation with a four-flanged technique. That's why I have put holes in the swivel haptics. Here it's not being used for capsulotomy fixated, but the same lens. So you don't have to have a standby lens. If you're using a swivel haptic IOL, then the same IOL can be used whatever the complication. Whether you damage the bag, you have an zonulidescence, or whether you have a PCR, you don't have to have a standby lens. You can use the same lens, so it is one lens which will serve all purposes. Even if you have it in a foldable, you can still use it in a multifocal. You can still use it for scleral fixation, even a multifocal toric.
So these are the pre-made, is it, sir? Pre-ordered lenses for the multifocals.
These are, multifocals we are not yet started. So first was the monofocals. We did the trial and we have published it in IJ also. Second stage is we are developing the torics, because for torics, it's a big boon. A capsulotomy fixated IOL for torics will not move at all, even by 2 degrees. So you have excellent correction of astigmatism. Unlike lenses in the capsular bag, which can rotate, there is a chance, 5 to 10% chance of rotation. And if it rotates more than 5 degrees, then you don't have a good refractive correction. So that's why I developed this capsulotomy fixated IOL. So now we are doing the clinical trials for the toric lens. And then the next stage will be a toric multifocal or a trifocal. But I just wanted to show a scenario where we can use it as a scleral fixation also, a foldable lens for scleral fixation, which can be in toric designs or multifocal. So you don't have to have a standby. The same lens which you're using for regular cases, if you have any problem, you can use it for scleral fixation.
Dr. Manish, sir, has a point. And then Dr. Navid.
Yeah, I had a question for Dr. Sri Ganesh. Dr. Sri Ganesh, brilliant technique and excellent innovation. I just had a couple of questions, sir. One question was, where is the hole in the swivel haptic located? Is it at the tip or it is slightly inside? That was my first question. How do you thread the suture when you are fixing it for scleral fixation? And my third question was, when you are if you are using a foldable lens, there will be 4 haptics which will be essentially folded onto the optic. So do the swivel optics, they kind of tend to, are they flexible enough to kind of fold on themselves?
Or withstand that?
Yeah. So the first question, yes, it is at the tip. The hole is at the tip.
Yeah.
And how I thread it is, it can just be put in a regular injector, any butterfly cartridge, regular injector, 2.8. Now we are also using it with 2.2. You can also use it with 2.2. So you inject the lens into the anterior chamber. And after that, you can introduce the 27 gauge needle, pull the proline, and then put it with the microforceps through the swivel haptic. You can adjust the swivel haptic so that it's comfortable for you to thread it in, then bring it out of the corneal wound, and then you flange it and then pull it. So that's how it is done. I had to fast forward because just 6 minutes I could not show. I just wanted to show some other interesting cases. And the material itself, the first iteration of the or model of the lens, we use PMMA haptics. And when you use PMMA haptics, sometimes through a cartridge, the PMMA haptics broke. So that was an issue with this swivel haptic with the PMMA. And so that was with hydrophilic. With hydrophilic, it doesn't break that easily, but then we came out with a hydrophobic. So what you saw was a hydrophobic material. And with the hydrophobic material, because it's a tougher material, if you put a PMMA haptic, then it breaks. So this was the issue which we faced. And then we did a lot of R&D. And then finally, this is a proprietary material, which is very tough. And it does not break. Even if it is twisted, it retains its shape. So you can put it even through a 2.2 mm cartridge and then nothing happens. So we have not had a single breakage or deformation of the swivel haptics. So this is something which is nice, but again, it took a longer time because of the material. We had to develop the material, and so I can't really, though we have patents, worldwide patents, until it's commercialized, we cannot give. I cannot give you the details.
That's understandable. I just wondering how does the folding take place when you are injecting? But brilliant technique and great innovation, sir. Congratulations.
Thank you very much.
Congratulations, Sri Ganesh.
Thank you,
That was a
Dr.
wonderful. So we shall now go on to our next speaker, Dr. Kiranji, who's again a senior.
Naren wants to make a point quickly, Naren.
Oh, yes, Naren.
Yeah, wonderful surgery, sir. As usual, very innovative and unique show skills, which you always show. So one question, sir, actually, the same thing how you showed I mean, like I mentioned earlier, I think four-flange is extremely easy for the fellows to start with. It's the safest, I feel, in terms of scleral fixation. And I was just wondering, when you did the swivel, where you did the flanging swivel after you extrise, then it was on the top. What if we start actually put it into the swivel haptics first, flange it below, so the flange is below the swivel haptic, so that it doesn't rub the iris when it's inside? What do you think, sir?
You cannot load the lens, no? So you have to load it through a cartridge. So if you flange it before loading into the cartridge, you cannot load it. So, what I do is, it's a foldable lens. It's a foldable lens. So I put it in the cartridge, inject it into the antechamber, and then I pass of course, it's much easier doing it outside. But if you do it outside, then you need a larger incision, or you have to use a folder. If you want to use a cartridge and then inject the lens, then you can't do it beforehand. So that's why.
What about
I think some of your consultants also have started using the technique for the PMMA lenses, Dr. Chaitra and some of the VR surgeons.
Yeah, absolutely.
So it's an excellent technique, very easy even for residents to learn. Many of my residents, they use it, and the complication rates are less, even when you compare it to iris clone.
So in terms of the swivel haptics, when you capture it onto the anterior capsule, have you looked at the PCO rates, sir? Because it'll keep the lens a little more stuck to the anterior capsule. Usually the lens design is where the lens is always pushed towards the posterior capsule to prevent the PCO. Have you found any increase in PCO rates, or is it the same? What do you feel, sir?
Yeah, in fact, this is a common question that is asked. But if you look at the whole, the way the capsular bag behaves after you put in a lens, there's a shrink wrap effect which starts at 3 weeks. So what we have seen, we have done UBM studies, and we have seen that the whole posterior capsule actually moves up. As the capsule shrinks over the lens, the posterior capsule moves up. So there is no potential gap between the PC and the lens. And these are 360-degree square edge again. So because of 360-degree square edge, once you have a shrink wrap effect, then it's fine. There's no problem. Again, there's a question of what will happen if the vitreous, will there be any kind of tug on the vitreous when the posterior capsule moves up and shrinks? But so far, we have not had any detachment or retinal tears or even a PVD immediately caused after the surgery. And most of these cases, they have a very weak Wagner's ligament. So basically, the anterior vitreous face is already detached from the capsule, poster capsule. So we don't see that problem. And PCO, again, we'll have to look at long term, but in about 1.5 years, we have not seen a higher PCO rate than regular lenses.
Sounds good. Thank you.
Thank you. Thank you.
We shall now go on to our next speaker, Dr. Kiranjit Singh, who's a senior consultant, cataract and glaucoma services from Daljit Singh Eye Hospital, Amritsar. And he's going to, again, a very innovative surgeon, and he's going to be showing his newer innovative approach. On to you, Dr. Kiranjit.
So I have a movie with a voiceover. Is it okay with you?
Yeah.
So before I start my movie, the lens which I'm about to show is how do I see my yeah, maybe it is like this. So it is just interior fixated IOL I'm going to show you, and it not only cures aphakia, it opens up the interior chamber angle. It helps to cure glaucoma. It does pupilloplasty, and it does so many. It deepens the interior chamber. So here I start my movie.
We can't hear any sound.
We can't hear any sound. You need to have the audio on.
Audio on. Okay, I can speak.
Yeah,
So
you speak.
this is a case of Marfan's, in which the patient has had a pars plana vitrectomy, lensectomy done elsewhere. So he came to me for a phakic rehabilitation. So I use this circular lens with 4 claws, and simply I stabilize the lens with a Clayman forceps, and with the help of a needle, 26 gauge or 27 gauge needle, I enclave the iris into the claws. And in 2-claw lens, you have some kind of pseudophacodinosis, but with 4-claw, there is no pseudophacodinosis. So this is first day post-op, and you can see the pupil dilates as well. This is a patient who was referred to me by a DSEC surgeon. He wanted a lens in the pupillary area so that he can use a air tamponade to secure the endothelial lenticule. So I separated the interior synechiae and did the same thing. The cornea was quite misty at that time, but you know, when you open up the interior chamber, the cornea clears up to some extent. So after doing the implantation of the lens, I do some interior vitrectomy and just see how beautiful the air stays into the interior chamber. And this is the post DSEC, and not the same patient, but some other patient, same situation. So this is a patient who had undergone therapeutic grafting for a corneal ulcer. And as you know, with the therapeutic grafting, there is leakage and chances of anterior synechial formation. So there was a membrane in the pupillary area as well. So what I did was I slipped this lens and enclaved the iris strongly into the claws, so that there is no chance of iris going back towards the angle and causing synechia again. So the patient had 36 millimeter of mercury IOP pre-op, and post-op he is stabilized at 10. You can see the deep interior chamber, no movement of the lens at all. So this is a patient with dislocated Morgaginian cataract into the interior chamber, gave a 5 millimeter incision, took out the lens, there was vitreous disturbance, and did some interior vitrectomy. Did the same thing of enclaving the iris into the iris claws. And after I'm done with it, I'll do some interior vitrectomy after making a small peripheral iodectomy. So it doesn't take more than 2 minutes to fix a lens. This is the Canacot to see if there is any vitreous in the interior chamber. So the patient is doing very. So this is a patient in which I have implanted the lens behind the iris at 4 places. So firstly, I hold the lens and I fix the inferior 2 claws. Then I push the rest of the lens behind the iris, make a peripheral iodectomy, which ideally should be done, and holding the lens optic through the peripheral iodectomy, I enclave the other 2 claws also. So Dr. Shri Ganesh was telling me somewhere that with 2 claws, there is bumping movement of the iris claw, to and fro movement. So with 4 claws, the movement just goes away. And after this, I think interior vitrectomy is a must. So if a patient has some kind of glaucoma, it also gets treated. So this is a patient with traumatic cataract with corneal tear. So I did the phaco and cut the fibrous band, which was in the pupillary area. Now I don't have any place to fix on the left side. So I create a slip in the fibrous band with the help of a 15-degree blade. So after that, I slip that slip into the claw on the left side and slip the iris in the rest of the 3 claws. So this patient ultimately regained vision of 6/12. The lens is very stable, no pseudophacodinosis, no glaucoma. So this is a patient of VR surgery with the iris fixated, retro iris fixated lens. So it got subluxated. So I just removed the iris from it and slipped in the interior, this 4-claw iris claw lens into the interior chamber and enclaved iris at 4 places. And the patient is very happy post-operatively. And you don't have to do much. No drilling holes into the sclera, no vitrectomy, and no self-retaining irrigating cannulas, no flaps, no glue, no sutures. And there is no vitreous anywhere. And synechnias also are taken care of. So this is the post-operative picture. The patient has 6/12 vision. Thank you very much.
Thank you very much, Dr. Kiranjit. Yes, and again, another very innovative thought process. It is just that there was a whole range of criticism for the iris lenses about ovalization and how to disenclavate it, and everything came up. Now, when you have 4 places to hold on, so the challenges are even more, no? I just wondered. I also realized it needs the same size of the incision as the iris clip, right? Same 5 millimeter?
Yeah, it is 5 millimeters.
5 millimeters. Okay. So I don't think you have answers for all those questions. No? I think if it is, you have learned the technique right, you would enclavate it just appropriately, and there is no question of disenclavation. I think once those learning curve issues are addressed, I think it should be another way of skinning the cat, right?
Is it primarily anterior chamber lens, or can it be done posterior chamber also?
You can use it for posterior chamber also.
But primarily you do it in the anterior chamber.
Anterior chamber, because I feel the presence of a PMMA optic in the anterior chamber will not cause any corneal decompensation. The corneal decompensation will happen only if the sizing of the lens is not proper, whether it is a iris claw lens or it is an angle supported lens. If it has posterior vaulting or anterior vaulting or movement in the eye or pseudophacodinosis, it is going to cause glaucoma or endothelial damage. But if the lens is stable, it cannot fire bullets at the endothelium through the aqueous. Nothing will happen. And I have not seen any of my cases developing corneal endothelial dystrophy with smaller version of the iris claw lens.
Yes, Manish.
Thank you.
Where is this lens available? Who's?
You know, I have filed a patent for this lens, and it is presently not available commercially anywhere. If you need one, I can always send you 1 or 2 across.
Sure, sir. Definitely. Right to you.
Thank you, Kiranjit sir. Very innovative idea. But as Chitra madam said, with the 2 clips only, we have concerns for the vitreoretinal surgeons regarding the dilatation.
No. This lens.
No,
this
but with the 4 clips hanging on to the iris, then how do we achieve a good dilatation if at all we want to have a vitreoretinal procedure?
This is what I showed in one of the previous movies. It constricts the pupil, but it lets the ability of the pupil to dilate as well. So in that patient of Marfan's, the pupil was able to dilate by 5 millimeters. So my question is, if somebody has done a glued lens and a pupilloplasty and pinhole pupilloplasty, 1.575 millimeter pupilloplasty, and the patient develops a retinal problem, what will you do? This is my question.
Agree.
Agreed. Definitely, we have to cut the pupil, or we use the iris hooks and try to stretch the pupil as much as possible.
So the trauma is going
that is there in the rare cases, sir, not all the cases. But this you are showing for the cases of aphakia.
Yeah. You know,
so these are the more common cases than the case which you just said now.
You know why I have shown the picture of Dr. Jan Wurst? Because he has shown vitreous is not just jelly which you can cut indiscriminately. It is a structure. It has cisterns, it has channels. So he has shown it with some dyes that it's a structure. You have bursa premacularis and there is channel going from up to down. So if you indiscriminately cut it, is going to cause trauma to the eye. It is not just jelly. So I am not cutting any vitreous. I am stabilizing the eye. I'm stabilizing the pupil. I'm stabilizing the iris. And if something goes wrong in the VR, you can always remove the lens if major thing happens. But you can always do a VR surgery through this lens, and you can do a DSEC, you can do a DMAC, you can do a PKP also. It is going to be helpful in any situation.
Removing the lens, how is it different from the 2-clip iris? Because disenclavation is itself a big challenge, and for 2 is a big challenge. Now removing it for 4, how do we achieve that? How do we do that?
We just go through a small incision, stabilize the IOL, then take a needle and just push behind the iris through the claw. The claws in this design are very big, so they are flexible. So it is very easy to push the claws down. And you can insert the 26 gauge needle through a stab incision of 0.8 millimeter. So it is not going to cause any leakage also. So it is not a big challenge. If people are doing so much things through the sclerotomies, this, that, this is something which you are seeing, and nothing behind the iris. Behind the iris, what we're doing is all blind procedures. You can always, you're trying to go through the pars plana. You can always go through the pars plicata and cause bleeding also. I talked to one of the doctors in Delhi. He said I started to do glued lens. In the first 2 patients, I had suprachoroidal hemorrhage. So even those things are very risky, going through the ciliary body, and complications are there. But in this case, I have not witnessed a single complication. And as far as endothelial count is concerned, it remains stable. And in one of the cases of therapeutic grafting, the endothelial count has risen from 950 to 1150. I don't know why.
Did we see a hole in the center of the lens in one of the cases?
Yeah.
Why is that?
Yeah, I am planning to make a lens with the aim in mind that the patients with very high hypermetropia or high myopia, I can make a phakic lens. Phakic lens in USA is approved one. It is FDA approved. So I can make a lens with 4 claws, small size, for very high hypermetropes, even with very shallow anterior chambers. Because I have lately done very high hypermetropes, and it is very difficult to manage those patients per-op and post-op, because you can have suprachoroidal hemorrhage, and you won't be able to fix the lens after you have taken out the cataract. I'm talking of clear lens extraction. So even that has complication. So I was just thinking of creating a phakic lens. For that, I need a hole in the optic, like you have in the ICL.
Okay. Thank you, Dr. Kiranji. There are lots to ask, but we have more speakers. Thanks a lot for putting in such innovative thought processes.
Thank
we
you.
go on to our next speaker, Dr. Ramurthy, who is the chairman of the the Eye Foundation Group of Hospitals and also a past president AIOS. And he's going to be talking on piggyback IOL, the indications and nuances. On to you, Ramurthy.
Thank you, Chitra, and thanks to ARC for this wonderful opportunity. I never knew that there is so much to secondary IOLs. Really a very innovative session and lots to learn for all of us. I hope my voice is clear and you can see my slide.
Yes, yes.
Okay. So what exactly is a piggyback IOL? It's essentially a supplementary intraocular lens to correct postoperative hemetropia. And to my mind today, also certain other imperfections that sometimes creep up with the primary intraocular lens. So essentially, some of the advantages of the piggyback lenses is that the cause of the refractive surprise need not be known. Whatever, whether it's wrong biometry, the wrong power of the intraocular lens being put, you need not worry about the other formula, how accurate they are going to be. Essentially, the residual refractive error is the only criteria for you to decide on the power of the piggyback lens. And it can be done anytime after surgery. It can be done 3 months later. It can be done 10 years later. It's obviously, especially if the capsular bag is fibrosed, and it's a lens which has been placed in the bag. Explantation of these lenses could be quite a challenge, and adding on a lens is easier. A large refractive errors can be handled. Nowadays, we have Indian manufacturers who can give you lenses of high hyperopia, astigmatism, as well as myopia. Multifocal as well as toric IOL options are available. Can be done even with corneal abnormalities. And one of the best things about any refractive surgery is whether it's reversible. Whenever you get an inappropriate outcome, all you have to do is to remove this lens and you are back to what you are originally with. And I'm aware of the fact that today intraocular lenses are given up to 65 diopters can be manufactured. But the point is that in these cases, the central thickness goes up to about 1.5 millimeters. The optic zone size decreases quite significantly. And these lenses come with a lot of spherical aberration, and which deteriorates the quality of vision. But the most important challenge to my mind, as I'll show in a subsequent slide, is the unpredictable biometry when you go on to such extremes of refractive error. And as I mentioned earlier, you have piggyback intraocular lenses of very high powers. This is a video which is about 20 years old when I had a patient who had undergone a refractive surgery, had an intraocular lens. The capsular bag is fibrosed, and you can see me putting in a piggyback lens of about 5 diopters. This is essentially nothing else but a 3-piece sensor intraocular lens, but which comes with a square edge optics. The primary lens that had been placed is a hydrophilic intraocular lens. The basic idea is to keep the haptics of the two lenses at 90 degrees to each other. But the point is, today you would not use a piggyback lens like this because they have a square edge which can rub on the back of the iris and cause pigment dispersion, raised intraocular pressure, etc. Obviously, it's not an appropriate lens for a situation like this. So another important concern which was voiced was that because earlier, the second lens was also, there was quite a bit of gymnastics that were done, and the second lens was also introduced within the bag. And it sometimes led on to a LE cell, lens epithelial cells proliferating in the interface. And then this was called a red rock syndrome. You could not YAG it, and sometimes both the lenses with the capsular bag had to be explanted. And that's one of the reasons that this procedure itself fell into disrepute. But that is about a couple of decades back. So it was realized that one of the nuances is that the primary lens and the secondary lens has to be of a different material. And most often, as we know, our primary lenses are hydrophobic in material, and we implant a hydrophilic intraocular lens, and that's in the sulcus and not inside the capsular bag. This is a custom-made piggyback lens, and it's available from the called the Sulcoflex lens, and no financial interest whatsoever. It's because of a hydrophilic material, is highly biocompatible, and it has a relatively large optic of about 6.5 millimeter and an overall diameter of 13.5 millimeter to 14 millimeter, which nicely fits in the large space of the sulcus. And one of the most important factors is the round edge optics, as well as though it's undulating, which gives the stability to the lens, it again is rounded, and because of which the chance of iris shaping, pigment dispersal, uveitis, and causation of raised intraocular pressure is significantly less. And because of the unique shape of the lens, where there is a 10-degree optic haptic angulation, the lens is kept away, the optics of the lens is kept away from the back of the iris again. As you can see over here, the other important feature is that there is a posterior concavity and an anterior convexity, because of which there is a significant separation between the primary lens and the secondary lens. If this was also convex, there is sometimes a tendency for the primary lens to push upon the anterior lens, and then result in inappropriate visual outcome. But then when you have a shape of the lenses like this and also a separation from the surface of the iris, then the uveal biocompatibility is also taken care of. This is again something that is shown in this particular figure. So the chance of optical aberrations and residual refractive error is again minimized. And today the Sulcoflex lenses are available in monofocal, multifocal, toric multifocal options. There are also Indian manufacturers who have come up with these lenses. Let's look at a Sulcoflex lens. Because it's a hydrophilic lens, it's dispensed in a sachet of fluid, and that's a large optics of the lens. And you can see it's almost 14 millimeters. This is a situation where the patient has already had a yak capsulotomy, and then you need a 3 millimeter incision, and because these lenses are fairly large. And that's a simple introduction. This is almost an unedited video. Just takes about a couple of minutes to slip in the lens. And because you are not disturbing the primary lens in any way, which tamponas the open PC, you do not have to really worry about the sorry, can you please mute us? You do not really have to. You don't have to. Hello,
ma'am, your mic is yeah.
Thank you. So you don't have to really worry about the open PC. The factor that I was talking about, this extreme case where the patient presented with a 17-year-old with a plus 10 diopter in one eye and a plus 17 diopters in the other eye, wanted desperately some kind of a refractive procedure to be done. Putting in a ICL was ruled out because the anterior chamber depth was just 2.2 millimeters. So the patient it was not just a question of cosmetics, but he was really handicapped with the very thick lenses. So we thought we will just go ahead and do a intraocular lens implantation. As you can see here, though the lens power might be available, the different modern formulae basically gave us all these different measurements. So right from 49 to 59 in the eye which had a plus 17 diopters refractive error, and from 39 to 44 in the eye which had plus 10 diopter refractive error. So essentially what we decided to go ahead and do a primary intraocular lens implantation, where I used a hydrophobic acrylic lens, a single piece lens of plus 40 diopters, which is commonly available. And then that's the first surgery which has been done. A similar surgery was done in the second eye. And what the visual outcome was that the one eye which had a lesser refractive error with a plus 40 diopter lens itself, he landed up with near emmetropia. In the other eye where there was a plus 17 diopters, subsequent to a plus 40 diopter implantation, there's a residual error of plus 6 diopters. The simple calculation is that for each diopter of hyperopia, you need 1.5 diopters of correction. So essentially, you need a plus 9 diopter of Sulcoflex lenses, what went inside. But in case you have a myopic residual refractive error, for each diopter of minus power, you need essentially 1 diopter of minus power. So that in case it was a minus 6 diopters, then it's a minus 6 diopters is the power of the lens that you would implant. As you can see here, for the residual plus 6 diopters, we are implanting a +9 diopter in the sulcus, and bilaterally implanted. This was the patient landed up with. Obviously, he had an asymmetric amblyopia in the second eye, because of which, even though the residual refractive error was just 0.5, he ended up with a 624 best corrected visual acuity, and in the first eye he had a 6.9 visual acuity. An extremely happy patient. Obviously, we can go into the discussion about doing a highly hyperopic clear lens extraction, but with the modern phacoemulsification technologies, this is something that's manageable. Another situation where a piggyback lens has come of use is a patient referred to me, a lawyer by profession, excellent toric intraocular lens implanted, absolutely emmetropic outcome. But basically, the patient was extremely unhappy with the negative dysphotopsia that he was experiencing. So essentially, what I used here was just a 0.5 diopters of refractive power. Basically, it's again a rounded edge optics which goes ahead and covers the square edge optics of the primary intraocular lens, which is nicely placed in the capsular bag. I did not want to yak the rim of the anterior capsule or bring the lens into the sulcus, simply because that would compromise the excellent refractive outcome the patient was already having. The moment we covered the square edge optics of the lens with the rounded optics of the secondary lens on the first postoperative day itself, the patient landed up with a complete cessation of his symptoms. I have done it in 3 other situations with the appropriate outcome. This is just to show you the postoperative clinical photograph as well as the ASOCT figures, which shows you a significant clearance between the primary lens and the secondary lens. The trifocal diphractic piggyback lenses have also become available today. And as you can see here, you come across patients who had a monofocal implant essentially and look for a multifocal outcome. This is an Indian manufacturer, and this is a quadripod design. And you can have a toric version of these lenses also. And once this lens is introduced into the sulcus, then quite often you can see it's a diphractic piggyback lens, and you get an appropriate visual outcome. And essentially, piggyback lenses, to my mind, applications are whenever you are ending up with a refractive surprise, when lens exchange is not possible, quite a significant residual cylinder, or when you have negative dysphotopsia, and when you want to introduce multifocality or trifocality as a secondary step. Thank you so much for your kind attention. Hello. I can't hear you. Can you? No, I'm not able to hear anything.
Sir, I am trying to speak. Can you hear me, sir?
Yeah, I can hear you very clearly.
Yeah, but I don't know. From Dr. Chitra's side, it's nothing is heard. So then, can I ask you something, sir?
Yeah,
if a lens is in the sulcus or partially an original lens, IOL, is the optic, the rexis has gone behind the optic. Is there anything we have of concern to place a sulcoflex lens?
I think, yeah, that's a very nice question. Obviously, there's a rexis runoff, but still most of the lens is in the capsular bag and it seems to be quite stable. Maybe you can still go ahead and place a sulcoflex lens. But if the entire primary lens itself is in the sulcus, then placing again a second lens in the sulcus might be a difficult situation. I have really not experienced that. I have not done that, handled a situation like that.
So original lens, whichever material is okay?
Ideally, what's recommended is that, the primary lens and the secondary lens should be of a different material. And since most often we are using hydrophobic acrylics nowadays, and both the Indian piggyback lenses as well as the imported lenses comes in the hydrophilic material, which is more uveal biocompatibility is better. and also separation from the iris is somewhat better. So these lenses seem to work quite well.
Sir, any particular scenario you would not place a scleral IOL? I mean, in sulcus IOL, like in case of, let's say, a large iris cyst, or any particular situation you would not place it, sir, or use?
Obviously, if the iris is badly traumatized, you have a large iris defect, or the patient is having a lot of dysphotopsia symptoms. These are not things that can be handled by a piggyback lens. Basically, this can handle only an inappropriate refractive outcome. And obviously, the primary lens has to be, as Vinu pointed out, if the primary lens itself has not been properly placed, and it's causing problems because of that, edge glare and other things, this may not really take care of that. But if the all your other things have gone well, but what you have to deal with is an inappropriate refractive outcome or a negative dysphotopsia, or you want to introduce multifocality, these lenses work well.
No, in the sense, I'm just trying to say, let's say, you position the IOL in the sulcus in a particular way because of the position of the iris, or you don't, in certain, if you have multiple large ones, you not implant it, or do you have any kind of a protocol for in those cases, sir?
Frankly, it's not that, though I showed a few videos, it's not that we have done a large number of these lenses because the requirement is quite less. So if you're asking me whether if there is a large iris defect or a iris coloboma, will you go ahead and use lenses? Is that your question?
No, sir. In let's say in phakic lenses, usually we look for all these irises and other abnormalities where we implant the IOL. It can lead to how the lens sits or the vaulting of the lens. In a similar way, you look at these kind of irises in a place where you're doing a sulcus.
I do agree with you. We do an ASOCT as well as UBM to make sure that otherwise the anterior chamber is the anterior segment is quite intact, and then only go ahead and implant these lenses.
Okay, sir. Okay.
Nice. Thank you, Ramurthy sir. That was a wonderful presentation as always, and it's always good to hear from you. Your tips, take-home messages are very crisp and a lot of learning points. Thank you very much once again, sir. So now we have our next speaker, Dr. Meenu Mathan, who is a very prolific surgeon and a very meticulous surgeon as well. And now today he is going to deal with us a very controversial topic. Is AC IOLs, does it have a stand today? Over to Dr. Meenu Mathan, please.
Okay, thank you, Dr. Chitra, for this invitation. And I'll share my screen. Am I visible?
Yes.
Yeah. So the topic was given to me. I did not choose this, but then she told me, do this. And I was very happy to do this actually, because I believe in this. And I will tell you why and how we should believe in AC IOLs. Do they have a role? I have no financial interest in this talk. So a couple of months back, we heard Dr. David Chang speak for a TNOA webinar, and he was placing an AC IOL in a complicated situation. So we mailed him, asked him, won't other types of secondary IOLs be better? So he told us, look at this, the ophthalmic technology assessment by American Academy. So when we went back and saw, it was published in Ophthalmology in 2023, and it is reviewed for currency in 2020 about different types of secondary IOLs. And they concluded that the literature supports the safe and effective use. This is a large meta-analysis of all the possible highly rated articles, not the weaker articles. They were all excluded. So the iris fixated and anterior chamber fixated and scleral fixated, they all had similar outcomes, and more randomized clinical trials will be required to identify the difference between these two, if ever it exists. So coming to AC IOL, I'm forced to use some slides in these presentations, which I generally don't do. But then the older generations once had problems of endothelial damage, UGH syndrome, and CM, cystoid macular edema. But the present day AC IOL, which is called the multiflex 4-point fixation, open loop, flexible haptics with rounded edges and the anterior vaulting, they are safe in ideal scenarios, because there is a you don't have too much of a leverage or too much of a freedom to do it in any kind of case in any way you like. It has to be very precisely done, and the IOL has to be well centered, appropriately sized, powered, and oriented. Very, very crucial. Without vitreous in AC and no iris tucking with the haptics, and the haptics ideally placed landing on the scleral spur away from iridectomies. So they are all available. A few companies still make them very regularly, 12 millimeters, 12.5 and 13 millimeters, which will suit most of the eyes, with powers ranging from 10 to 25 diopters. So as a dictum, sizing would be a white to white measurement plus 1 or even 1.5 millimeters. Too large an IOL for too small a white to white will cause ciliary tenderness and erosion into the ciliary body through the angle to the limbus. We have seen ends of iris, the lenses coming out. And if it is small, again, it moves. And pseudophacodonosis is very crucial. But we should know that pseudophacodonosis should be differentiated from the subtle movement of the iris, which we see, because there is no vitreous behind, and the lens casts a shadow on the iris. And when you see the eye moving under the slit lamp, you will see you think that the lens is moving. But if you look carefully, it is a reflection of the IOL on the iris moving, and the iris is the one which is moving and the lens is not moving. So many people consider a stable AC IOL to be having donesis, looking at the iris which is fluttering. And again, it can cause pigment dispersion and uveitis if it is small size. So choose wisely in placing IOLs, especially in younger age group people. So today I did 2 secondary IOLs. Both were in their early 50s or late 40s because of trauma. Both I did glued IOLs. So an older age where they have fewer years to live and endothelial cells will not progressively go bad and go have an endothelial problem, you can always choose them. And surgical trauma depends on how much of surgical trauma you have induced. So don't blame the IOL just with the IOL for all the complications will follow. The original the surgical trauma has to be assessed and then come to a conclusion whether you can safely place this IOL or not, by looking at the endothelial status in all cases. So nowadays we do a specular microscopy for all IOLs, all cases. And a very shallow anterior chamber with chronic angle closure, a gonioscopy has to be done before placing an AC IOL, and sizing and power is very, very important. And once we decide to do this, it's quite simple technique, and it's very quick technique and very minimal learning curve. Let me go into few details of the technique. Vitrectomy is mandatory. I would do, even if there's the slightest of vitreous disturbance, or if it's a bulging anterior vitreous phase, I would do a vitrectomy. And then once the vitrectomy is done, the pupil size we should consider, and most of them will constrict with pilocarpine. So intracamerally, we can use pilocarpine and let it constrict smaller than the size of your optic. And then a peripheral iridectomy. Very, very important that you do one quite sufficiently large one. And nowadays I do 2, and they should be adequately sized and should not be plugged with vitreous. That is another thing. So we should do an anterior vitrectomy so that the incision, this is not the ideal incision which you should make. The corneal incision should not be unnecessarily extended this much, but then we can always suture this. 5.5 or 6 millimeter optics are available. While introducing, please make sure you don't tuck iris along when you're pushing it. And once the trailing haptic is partially gone in, I do not push too hard, because once you push too much, the leading haptics can press too much into the iris root and it may cause bleeding sometimes. So I will tuck it in with a Kugler's hook by pushing slightly from the periphery. And also a gentle rotation so that it doesn't cover much of the peripheral iridectomy. Some part of it always can be covered, but most of it should be uncovered, and the section should be definitely closed. And this is another case just to show you that this is an intraoperative conversion. This is a intraoperatively the whole bag was taken out, and so we go ahead with the vitrectomy. So bimanual vitrectomy is very crucial. Close your main incision. Don't do vitrectomy through the main incision. Use bimanual, appropriately sized see the size of your vitrector, whatever you have, and do an appropriate vitrectomy. Not too much, but then adequate enough to clear your anterior vitreous, and make sure in this case there was already a PI there, a YAG PI, but I'm now measuring. definitely many of the cases, the horizontal will be larger. This is 11 millimeters and the vertical is slightly smaller than that. But horizontally, if it is 11 millimeters, you can very well place a lens. And I do another PI just to be safe, that the other YAC PI might be very small. So I do one more peripheral iridectomy and then place the IOL. So as you can notice, it goes smoothly under sodium hyaluronate. I place sodium hyaluronate under the on top of the constricted iris and tuck the haptics in a little, because this is not ECC incision. It has to go through the intercorneal lip. So it has to be tucked in without pushing the leading haptic too much into the angle. And now make sure irises, if there is small tucking, you can just hold onto the haptic and release it, lift it, and turn it a little around, and make sure the tip of your leading or trailing haptic open end should not go through the PI. Very important. When we dial, sometimes we'll be looking at the optically, the haptic tip of it may get into the PI and it may disappear. And lastly, some trauma cases, the pupil, even after using pilocarpine, may not come below 6 millimeters. So if it is not coming below 6 millimeters, and if you need to use this, you can always do a pupilloplasty and make it smaller than the optic. That is what I would want to have it, because later on it should not be capturing the optic and the iris may go behind the IOL, and that can cause distortion and other things. So if it is smaller than the optic, that's fair enough. And after doing it, now the most important thing is this: the lens comes in a packet in which it is loaded like this, like our PC IOL. So there is always an anterior vaulting of the optic. Then the lens is placed on the cover like this. So whenever after opening it, hold it and flip it. That is the way it should go in. So it should not be facing backwards, and from the cover, you should not be directly taking it and placing it into the anterior chamber. The vaulting should be facing anteriorly to prevent pupillary block, and see that the haptic, the end of the haptic is not within the inner lip. Many times it happens that one haptic may be within the inner lip of the incision, and that can cause leakage and can cause later on problems. Any problem with the incision, please do put sutures. And I would suggest, do not blame only the anterior chamber IOLs for all the problems. And with all these criteria and the investigations done, we can get equally good outcomes in planned cases of anterior chamber lens implantation in cases of aphakia. Thank you very much.
Thank you very much, Dr. Menu. That was a wonderful talk. I wanted to ask you about the choice of viscoelastic. You did tell. The other thing is, I'm sure, although you spoke very significantly about AC IOL, you are still using it in your surgical practice. And if you are, then when do you do an iris clip lens? When you do SFIOL, and when would you do a AC IOL? Could you tell me that?
My two options are in front and behind the iris, not on the iris. Nothing personal about iris or iris flow lenses. Nothing personal. I do not do iris sutured. I used to do iris sutured, but then that also not. I don't think they are too stable in my hands. So whatever works well in my hands, I'm doing. The glued IOLs are working very well for younger age group people, and in cases where you do not place an AC IOL, but then AC IOLs in the situations which I enumerated can be used in a very calculated manner, with perfecting each step properly and investigating very well properly. We can give you best results.
Yeah, thank you very much, Dr. Minumathan. We shall now go on to our next speaker, Dr. Purinder Bhasin, who is the founder and director of Ratan Jyoti Netralaya Ophthalmic Institute and Research Center. He also has a huge multi-specialty setup adjacent to his ophthalmic setup. So quite an entrepreneur to be reckoned with. And he's going to take us on to dislocated IOL bag complex, different approaches. On to you, Dr. Purinder Bhasin.
Thank you, Dr. Chitra. Just a few seconds to share my background. Can you see my screen?
No.
One second.
So just click on the green button on the Zoom window.
Yeah. Is it visible now?
Yes, sir.
Okay.
Yes.
Thank you. Thank you for giving me this opportunity for this interesting webinar. I really appreciate the variety of lenses and the techniques which has been discussed here. It is really very learning experience for me too. And dislocated IOL back complex. I will be sharing few of my cases which which I have done in my practice. And this is a case of 82 years old patient who had a pseudo exfoliation. We did the 3-piece lens, hydrophobic acrylic lens in the past. And one fine day after 12 years of the previous surgery, he came where we saw that the whole lens bag is subluxated along with the IOL. So with the backup of the retina surgeon, because I was not sure whether we will be able to retrieve this from the anterior approach. And as you can see, there is a CTR also to distend the leg back. And the pseudo exfoliation cases, the zonules are weak. So we usually put a CTR in these cases, and this was there. So what we are doing is I'm holding the lens with my left hand with the IOL holding forceps, and I have done with the vitrector, I have removed all the capsular this thing from around the lens. And now by handshake technique and hand-on-hand technique, I'm pulling out the haptic of the lens, and once in the other side, I am tucking it, the glueless glued IOL, which I have done in this particular case. So the haptic is stuck in the scleral tunnel. It's not a flap, and almost 1.25 to 1.5 millimeter of the haptic is stuck in the tunnel on either side. And this is the end of the thing. And we have sutured it. And the VR surgeon has seen the posterior segment at the end of the case. Another case, this is very interesting. This patient had a complicated cataract in both eyes. This eye was operated at Kanpur, and he came for the other eye with us. And other eye, we did a synechiolisis and everything, and like any other complicated cataract, we managed it. Now he came for this other eye to us, and in this eye, the lens is, as you can say, in the anterior chamber. One of the haptic is also in the anterior chamber, and the iris is atrophied, and the anterior chamber is very shallow. And in this place, at this place, there is a deficient iris also. So it's a complicated surgery which has been done, and there is a thick after cataract, and the synechias, dense synechias are there between the iris and the posterior and the capsule of the lens. So what I did a paracentesis incisions at 2 places, and then I went underneath. I filled the chamber with viscoelastic. I went underneath the IOL and released the iris, cut the iris at places, and I have filled the gap of iris and the lens capsule with the viscoelastic. And with the help of the iris spatula, I have, with the sweeping movement, I have created the sulcus. And the same lens I placed in the sulcus. Now this iris defect was also there. So I sutured it so that there is a less of glare. And as you can see, the iris is largely atrophied and very thinned out, and at multiple places there is a thinning and iris defect. So the same lens and sutureless technique, I refixated or replaced the iris at the place where it should be, the lens where it should be. And this is the pre-operative vision, and the case of the 2/60 was the best corrected vision pre-operatively, and the patient improved in 2 months' time to 6/12, and luckily after that he has not visited to us. Another interesting case, this is a plate haptic IOL, and there is the strand or a band of the capsule present in the center. and there is no capsule on the either side of this band which is there in the center, and this plate haptic is sinking in towards the anterior vitreous. So what we did, we again brought this lens in the anterior chamber, safer place, and we made a tunnel 180-degree apart, and a proline suture is passed through the haptic or the opening in the plate haptic from behind the lens, and another needle is passed then, and the same suture is railroaded back, and we get a loop of the proline suture around the haptic. The similar thing is done on the other side. We have passed the proline suture from within the haptic of the opening of the plate haptic, and the two ends are then tied, and we have seen that it should not be too loose or too tight, and the chamber is found throughout. And we did the automated anterior vitrectomy. Pupil is made small, and the tunnel is meant to place the knots of the proline suture, and the cauterization of the conjunctiva is done. Same lens reposited in such a condition. Another interesting case, this is a PC rent, horizontal PC rent, as you can see, and there is an intact capsular axis. So what I have seen in this particular case is that a hydrophilic lens is placed, and this hydrophilic lens is placed in the sulcus, and it is not in the bag. Because of the PC rent, the surgeon has not put this lens in the bag. So the problem was that this lens was rocking. So he came to me after a week. As you can see, the part of this whole lens is moving in the eye. I'm doing a topical anesthesia, and what I did was I engaged the optic of the lens in the capsular axis, which was intact. And this we did after a week under topical anesthesia. So this is what it is, the anterior capsule, as you can see, remove the anterior capsule. And this is the above and two other ends. So the haptics are in the sulcus, and the optic is engaged in the capsular axis. Otherwise, if you would have put the lens in the bag, it would have stayed. Last case, this is a PMMA lens, and there is a PC rent again with the fibrous margin, and the capsule is present on either side, and the lens is behind in the anterior vitreous. Luckily, it has not fallen back. So this patient came to us with the subluxated lens in the anterior vitreous. We retrieved this lens, pulled it out, and the haptic is pulled out in the anterior chamber. And through the paracentesis in wounds, I dialed this lens in place. As you can see here, I dialed this lens on the fibrosed anterior the capsule remnant which was there, and I could find that there was sufficient amount of capsule present, and these PMMA lens really usually they are large size, so they don't slip back, unlike the three-piece lens or hydrophobic acrylic lenses. So the same lens is now placed in the sulcus over the capsule remnant. So this is how we retrieve them, and we manage these cases. So these are the variety of cases which I could find from my practice, and which I have shown over here. Thank you.
Wonderful, wonderful. Truly innovative surgeon, Dr. Purina Basina. As soon as this topic came, you're the first person who came to my mind. Thank you so much. Dr. Manish or Dr. Aniruddha, whoever is there, or I want to ask you all this question because it's the domain of the retina surgeon. Supposing the topic was IOR bag complex. So often a CTR would also be there in the bag. How would you
Muted now.
So CTR, as you can see in my first case, which was a IOL bag complex.
No, the question is, do you remove the IOL or the CTR first? Which comes before, which comes later? So I can hear.
Can you hear me?
Yeah.
So I think the whole, if at all, if you are removing, then you have to remove everything in toto, and you have to make a large scleral tunnel, and you have to bring it out. But in large cases, in majority of the cases, we have to remove completely. But in this particular case, we have removed all the capsule from around the lens, and at the same time, we have removed the CTR also. So first thing is that to hold the lens and remove the CTR, it comes out with difficulty because it is engaged at various places in the fibrosed with the anterior and posterior capsule. So it comes out with difficulty, but with efforts, you can easily do it.
No, if it is deep in vitreous, I wanted the vitreous
The
surgeon.
retina surgeon will tell this, I think.
That's what.
Srinivas and Manish is there.
Yeah, that's
Ma'am,
why.
after vitrectomy, once the IOL bag complex is free, usually we remove the CTR first, and because it is easier to dilate out, and then remove the IOL.
Yeah.
So,
That's
What we ideally do is, in case of CTR IOL back complex which has fallen down, if it's a 3-piece IOL, we try to first bring it to the AC, and then we can remove the CTR and use the same 3-piece IOL, externalize the haptics, and then we can go ahead. But if it is a single piece with that, then ideally it's better to remove that down and then introduce the whole set of whatever is best suited by the surgeon and whatever is by the surgeon and whatever is the.
Yeah. Thank you, Ashray. Thank you, Srinivas, for the thing. We go on to our last speaker. I'm very sorry, Dr. Manish, that we were so running out of time and so disorganized we were.
Vitreoretinal surgeons are ready for these things.
So novel and interesting. It seemed to be necessary to ask some very basic questions. That's why we got delayed. Dr. Manish heads the Vitreoretina Uvea and Neuro-Ophthalmological setup at his Dr. Bapai Hospital, Nasik. And he is going to be talking on a very important topic, secondary IOLs combined with VR procedures. On to you, Dr. Manish.
Yeah, thank you, madam. At the outset, I would like to thank you and ARC for giving me this opportunity. It has been a very learning experience with so many different approaches of secondary IOL being discussed. My preferred approach is to do glued IOL, which I find very elegant technique. However, I'll be discussing some cases where we have done secondary IOL with the secondary IOLs with some VR procedures. So vitreoretinal procedures, we have to do it frequently with secondary IOL implantation. So as secondary IOLs with some VR procedure to make that there is no vitreous entanglement when we are removing the when we are externalizing the haptics, or when we are suturing the haptics with the suture, where we are using suture techniques. We also need to make sure that there is no associated VR pathology, and if it is there, that needs to be taken care of. It might be associated with dislocated nuclear fragments or cortical material or dislocated IOL. So in cases of IOL dislocation, refixation or replacement needs to be planned. So we need to decide we need to have a treatment plan when we go inside in these cases. So case one is that of a 68-year-old male who had undergone cataract surgery 1 year back and complained of sudden onset vision loss of a few days duration. At presentation, intraoperatively, we could see that there was well-placed anterior chamber IOL and clear cornea. But when we went inside, there was inferior RD and there was a second IOL which was there in the vitreous cavity. So scleral buckle was placed and then vitrectomy was started with 23 gauge. It's an old video. So the vitrectomy was completed so as to make sure that the IOL was separated from all its vitreous adhesions. There was superior RD with the HST which can be seen there. And as the peripheral vitrectomy was done, there was a small superior break which was created in the 12 o'clock meridian. At this point, we injected some LPFC and flipped the IOL over LPFC bubble with my left hand, and then the scleral incision was made, and the anterior chamber IOL was removed, and it was kept in the BSS. At this point, the PMMA lens was explanted, and the AC IOL was re-implanted in the anterior chamber. There was already a large PI was there. We made sure that the lens was stable, and then we proceeded with the posterior segment surgery, where the breaks were cauterized so that we could see them after fluid air exchange was done. The fluid air exchange was done to reattach the retina. The laser was done around a posterior break, which was a primary break, and cryo was done to more anterior break, which was a iatrogenic break. And the C3F8 gas was injected. Scleral buckle was tightened, and case was closed. The patient had very good outcome till the 6 years after the surgery. He had 6/9 vision and the well-placed IOL with clear cornea. The second case was that of a 65-year-old male patient who was referred by the surgeon, who had intraoperative posterior capsular rent, and IOL was dislocated. So intraoperatively, initially the scleral flaps were made at 3 and 9 o'clock position, and the sclerotomies were made. The anterior vitrectomy was done so as to make sure that the IOL was separated from all its adhesions, and then posterior segment surgery was done, where we can see the vitreous, which had hemorrhage also, was cleared. The cortical material which was there was removed with the cutter itself, but the nuclear material which was entangled was left as it is at this point of time. Then the sclerotomies were made under the scleral flaps, and the IOL was lifted. As I was trying to externalize the haptic, it was slipped. So again, it was held with the edge of the optic, and the temporal slipped. Temporal haptic then the nasal haptic was externalized, and it was tucked in the scleral flaps. The sclerotomy on the temporal nasal side was enlarged, and phacofragmatome was used to remove the nuclear material, and the case was closed with fibrin glue. The patient had very good visual outcome. The third case was a 80-year-old female patient who had known case of high myopia prior to cataract surgery. She had undergone cataract surgery 15 years prior to presentation and presented with sudden onset vision loss of 3 days duration. And in this patient, there was dislocation of capsular bag, and IOL complex was dislocated. So here we planned for glued IOL. Initially, the flaps were created, and the sclerotomies were made after the flaps created. I like to make paracentesis opening so that it gives us, it gives us maneuverability in the anterior chamber also. So 25 gauge sclerotomies were made, and the paracentesis there. Complete vitrectomy was done. Complete posterior vitrectomy was done, and the making sure that there was no residual vitreous. We made sure even the base excision was done so that when the anterior chamber, the scleral fixated IOL is put, there are no problems there. The lens was explanted and brought on the iris, but one of the haptics broke. Since it was a PMMA haptic, it was removed, and then the limbal incision was made, and the rest of the bag and the IOL complex was removed. The pupil had become very small, so I initially tried to put intracameral adrenaline. When that did not work, a little bit of stretch pupilloplasty was done, and then the sclerotomies were made under the flap, and standard the glued IOL technique was done with 3-piece lens. The temporal haptic was externalized using handshake approach, and patient had very good visual outcome. The final case is that of a 35-year-old female patient who had scleral fixated IOL, which I had done 10 years prior for traumatic cataract with the traumatic dislocated cataract. But at that time, I had done the glued, I had done the sutured IOL, and the patient 10-0 proline was used, but the patient presented with sudden drop in vision following trivial trauma. At this, in this patient, the temporal haptic was very nicely attached. The nasal haptic had dislocated, so the scleral flap was made, and we put in a trocar. The IOL was brought onto the haptic was brought onto the iris, and the cut suture end, the broken suture end was trimmed. The straight needle on 9-0 proline was passed behind the iris, and then it was passed through the eyelet in the haptic of the lens. Care was taken that not much pressure is put on the haptic, which was well attached. The needle was externalized. Then it was railroaded back from the 26 gauge needle, which was passed on top of the haptic. Once it was threaded back, the haptic was sutured in hangback fashion, and the knot was buried. And the patient had the conjunctiva was closed with fibrin glue, and the patient had very good outcome at the end of the 1 week. So to conclude, posterior segment pathology can frequently coexist in these scenarios, and combined anterior and posterior segment approach is frequently required, and in my opinion should be done in majority of the cases, so that we are not we have to be sure that we are not causing any giant retinal tear or retinal breaks inadvertently, which can cause problems at later stage. A tailored surgical approach is necessary in most of the patients, and posterior segment pathology has to be effectively managed for satisfactory visual outcome at primary stage, or if unfortunately so required, at secondary stage.
Thank you very much for the wonderful examples which you showed. I'm going to ask a very basic question. How would you prevent a silicone oil migration when you are placing a SFIOL after a retinal surgery?
Madam, whenever we are doing a secondary IOL in any manner, basically when there is no capsule to tamponade the oil, we have to treat it like a aphakic case. We have to do an inferior PI and reform the AC with BSS to make sure that the oil is not coming in the anterior chamber. It has to be treated like a aphakic case, and necessary things have to be done.
Yeah.
One question, this thing to answer you, madam. Silicone oil is it's like a jelly. It is held up by the van der Waals forces. It doesn't escape like a liquid or the water. So unless we put more infusion and overfill it, that is when the counter pressure gets decreased, the AC gets decreased, and then the oil enters into the AC. Otherwise, if you do a proper fill of the silicone oil, it doesn't get entered when you have a scleral fixated IOL in place. Unless it's an aphakic this thing, in scleral fixated, it usually doesn't come.
If it's an aphakic eye and you're doing a SFIOL now, then I wanted to know.
Yeah,
Even then,
still do an inferior PI.
Ma'am, just to add what Srinivas sir was telling, if there is a overfill, it will definitely come to AC. So with the newer instruments, we use something known as a vent, which we put it into the other port and while filling. So if there is an egress of any silicone oil, we stop at that point. So by the surface tension of the silicone oil bubble, it stays behind the IOL. It doesn't come into the AC. If at all, you have to combine.
Maiti sir, your thoughts?
Yeah, I think that's a generally the first case, I think it was detachment along with an SFIOL, right, Dr. Manish?
Yeah, it
Yeah.
was. It was
I think
actually,
we
it was a
had-
piggyback lens where the primary lens had dropped.
Yeah, but
So,
parent and all, you have to just rely on that IOL calculation primarily to be right, no? Because you're using the same lens and it's a detached eye, so you can't do any axial length measurement and all that. So when you're using the same lens which has dropped, there are certain challenges in the IOL power being appropriate.
my experience is that usually where the primary lens is dropped, the surgeon has done a scan in a more controlled fashion preoperatively. More likely than not, the IOL power will be suitable for that particular eye. So it is more challenging to calculate IOL power in these patients when we are trying to replace the lens rather than refixate. That is my personal experience.
Yes. Any other point to be discussed before you close for the day? I think it has been lots of knowledge which has been thrust into our heads in the last 2.5 hours. Srinivas, unmute yourself.
Yeah, one last point I wanted to ask. Sir, in the VR perspective, what is your final choice of SFIOL? What's your dream choice of SFIOL? There are so many plethora of techniques which have been discussed. And what is your favorite choice? Anticipating that there is going to be a VR surgery in future, there is going to be a silicone oil or the C3F8 gas has to be put in that patient, a high myop or whatever it is. What is your choice of IOL? The last question.
Yes.
Is the question for me or Dr. Maiti?
It is Dr. Manish Bapai.
Okay. My go-to technique in these patients is to do glued IOL. I'm very comfortable doing that. It's very the
You mean
IOL power.
externalizing the haptics and putting it into the scleral tuck?
Yes.
Because I think
Anirudh,
it's absolutely personal choice. Mostly I do iris claw lens unless and until the iris is damaged.
Yes.
And I have done RD surgery also with the iris claw, so I'm pretty much comfortable with
Yeah.
it.
So I'm more like Dr. Minupad Mathen. I accept his philosophy of not messing around with iris as much as possible.
No, I think a good surgical technique is what is important, and that's the message we get, and there are multiple ways of doing it. Dr. Naren Shetty, any last thoughts of yours?
Last choice of IOL, your choice of IOL.
No, last
I just want to say that again, I want to stress on the fact that it really depends on there's nothing like best technique. As of now, it is clearly, I think from this whole talk, we can say whichever works the best in your hands, please follow it. I mean, for me personally, Yamani technique, works well in my hands. But otherwise, I feel it's nothing is very superior over the other. There's always pros and cons in each technique. So always do the one which you're able to give consistent results and and good results. Yeah.
Thank you.
Thank you very much.
Over to Chitra madam.
Yeah, and as we conclude, I think we need to thank all the expert panel and every single dynamic speaker at such innovative techniques. And I mean, just it tells you how a human mind can work if allowed to work. So it's truly, truly impressed by it. And thank you, Srinivas, for being a wonderful moderator, which you have always been so consistently. And at this juncture, I need to thank Kripal and the admin team. I need to definitely thank Entoad for sponsoring all our webinars. Thanks to Sunil. Sunil was relatively quiet today. Thanks a lot, Sunil, for being there. But then you're always a troubleshooter. There was hardly too much of a need to do that. So thanks a lot for being there. And finally, and most importantly, I need to thank all the delegates who have been there every time. And even now when I go for different meetings, the way they receive me, it tells me that how useful they found these webinars. And probably that has been that one encouraging factor for us to keep coming back with different flavors and different ways of presenting to all of you. Thank you so much. Thank you very much.